today's program. Good evening, everyone. So today is Ram Navami, and we all know that the Ram Navami is very special to our heart. And I just want to start today's program with one beautiful slokas of Rama. Om Apodamaya Hartaram Datarang Sarva Sampradam Lokabhiramang Sriramang Bhuyo Bhuyo Namamaham. So why it is important, Ramachandra give importance to that little squirrel also. And today we are going to discuss one disease which is actually denoted as a rare disease like thing, rare endocrinological disease, and we often miss it in our regular curriculum. But it is also important to note that though the number of Indian suffering from Addison's disease is less than 10 lakh per year, but there are so many individuals are still suffering from Addison's disease and these adrenal related disorders. So we need to know about this, and for that Indian Pharmacological Society West Bengal Chapter and Inovocare Health Soft Solution, Inovocare E-Academy is organizing this Therapeutics CME on Addison's disease. So to start today's program, we have our President, Sir, Professor Tapan Kumar Mondal. I request, Sir, to have his welcome address. Then we will start today's scientific lectures. Over to Professor Tapan Kumar Mondal, sir.
Good evening. I am audible, Sambo?
Yes, sir. You are audible, sir.
Yeah. I, on behalf of IPS West Bengal branch and my own behalf, welcome the learned speakers, IPS members, and the participants to this interdisciplinary continued medical education on Addison's disease, virtually organized by IPS West Bengal branch with technical collaboration from Inovocare E-Academy. Addison's disease, also known as primary adrenal insufficiency, is a rare long-term endocrine disorder characterized by inadequate production of the steroid hormones, cortisol and aldosterone, by the two outer layers of the cells of the adrenal gland, that is adrenal cortex, causing adrenal insufficiency. And symptoms generally come on slowly and insidiously and may include abdominal pain, GI abnormalities, weakness, etc., that you know very well. Around 0.9 to 1.4 per 10,000 people in the developed countries are affected with this disease. And it occurs mostly frequently in middle-aged females. And it is named after Thomas Addison, a graduate of the University of Edinburgh Medical School, who first described the disorder in 1855. And the participants today, they will be benefited from this CME program on Addison's disease in respect of pathophysiology, clinical diagnosis and management, which will be delivered by our learned speakers. Heartfelt welcome to all the speakers like Dr. Rahul, Valsaraj, Consultant Endocrinologist, VPS, Lakeshore Hospital, Kochi, Dr. Arindam Ray, Consultant Endocrinologist, Kolkata, Dr. Anirban Majumdar, Professor of Endocrinology, KPC Medical College and Hospital, Kolkata, and Dr. Soibal Das, Clinical Pharmacologist and Scientist, ICMR. Heartiest welcome to the panelists, Professor Nilanjan Sengupta, Head, Endocrinology, NRS Medical College and Hospital, Dr. Madhu Chandakar, Medical Oncologist, Peerless Hospital and BK Roy Research Center, Kolkata, Dr. Jyotirmoy Pal, Professor of Medicine, Arjikar Medical College, and Dr. Abhijit Hajra, Professor of Pharmacology, IPGMER, and past General Secretary of IPS West Bengal branch, and also Dr. Sambo Samazdar, who is the mediator, who is the moderator, as well as the branch secretary and the dynamic personality. So with this, I wish this program a grand success. Over to Sambo.
Thank you, sir. Thank you very much. So now it is our real honor to have our first speaker on board, and we have Dr. Rahul Valsaraj, who is a very young dynamic endocrinologist. He had done his DM in endocrinology, DNB in endocrinology, and also SC from UK in endocrinology. Currently, he is a consultant at Department of Endocrinology, VP Lakeshore Hospital, Kochi. So may I request Dr. Rahul Valsaraj to start today's program with his talk on adrenal disorders, focusing on the pathophysiological considerations. Over to Dr. Valsaraj.
Thank you so much. Thank you, Indian Pharmacological Society, West Bengal, and thank you, Dr. Shambhu, for inviting me. Even though I'm far away from Kolkata, but Kolkata still is very close to my heart. My son was also born over there, so I love taking part in all programs whenever I'm invited from Kolkata. So thank you for the invitation. Let me just share my slides. I hope you can see my slides.
Yes, we can see.
Okay. So I'm glad that such a topic is going to be discussed tonight, because it is these Addison's disease and adrenal insufficiency. It is commonly missed and it is misdiagnosed, and if treatment is not given at the correct time, it could be catastrophic. So today my topic will be focused mainly on the pathophysiological considerations regarding adrenal insufficiency. I'll not be talking about Cushing because I think that itself is a CME by itself. So I'll be talking mainly about adrenal insufficiency. So as we know, the adrenal gland or the suprarenal gland, you have the adrenal cortex and the adrenal medulla. And the cortex is divided into zona glomerulosa, which secretes the mineralocorticoid, that is aldosterone and corticosterone. And then we have the zona fasciculata, which from where the glucocorticoids are synthesized, that is cortisol and cortisone. And then you have the zona reticularis, from where the adrenal androgens such as DHEA and DHEAS is secreted from. And as you all know, you have the adrenal medulla, from where we have the catecholamines. So what is important to know is that both cortisol and the adrenal androgens is regulated by the HPA axis, that is by the hypothalamo-pituitary adrenal axis, and zona glomerulosa is regulated by, that is the mineralocorticoid synthesis and secretion is controlled by the RAS system. So it is important to know that. So when we have a pathology of your primary adrenal or secondary or tertiary, this is the main important thing which we need to remember. One will have mineralocorticoid deficiency and the other will not. So because these both are separately controlled is why that happens. So depending on if it is primary, secondary, or tertiary, primary adrenal insufficiency is when the it's also called adrenocortical insufficiency, is when mainly the adrenal cortex is involved. In some conditions, both cortex and medulla can be involved, such as your hemorrhage and infiltration and infections. But mainly, usually, it is the cortex which is involved. Apart from that, you have the secondary adrenal insufficiency, that is the pathology is in the pituitary, at the level of the pituitary. And finally, you have tertiary, which is at the level of the hypothalamus. So as you can see in this slide, you can see that in the primary one, you have deficiency of mineralocorticoid, you have deficiency of glucocorticoids and your adrenal androgens. Whereas in secondary and tertiary, you don't have deficiency of aldosterone because it is controlled by the RAS system. So as I mentioned, these are the three main types of adrenal insufficiency. What we see mostly is secondary and tertiary because of excess glucocorticoid use for various reasons. May it being quacks, may it being for autoimmune diseases, made for joint pains. So all these things, we do use steroids on a regular basis. So, and even with COVID, this is more and more happening. So secondary and tertiary is what is more commonly seen than primary. And if you're looking at the presentation of adrenal insufficiency, it can be both acute and chronic. And most of the time it is chronic and we tend to miss out. So because the symptoms are very non-specific. So the symptoms, the presentation of adrenal insufficiency depends on so many factors. It depends on the rate of loss of adrenal function. So usually the symptoms come only when there is more than 90% loss of adrenal function. And how much of adrenal function is lost? So if it is a slow rate of loss, so the symptoms will not be that prominent in the starting. And only if there's a precipitating event, such as some sepsis, diarrhea, some major surgery, then can it present. And many of the time, patient may just have some fatigue or something like that. Then the other presentation depends on if there is mineralocorticoid activity is involved or not. And finally, it depends on the severity of the stress. If you have a very severe stress, such as a severe sepsis or severe road traffic accident, major surgery, then it can present as a very acute adrenal crisis. So because of this wide variety difference in presentation, often this is misdiagnosed and overlooked when it is the chronic phase. In acute adrenal crisis, majority of the time they'll present with shock and electrolyte abnormalities. So majority of the time, because of shock, we do tend to give hydrocortisone or some steroids. So because of that, even though we don't know whether it is adrenal insufficiency or not, we tend to treat it. So that's what usually happens. So if your adrenal glands in primary adrenal insufficiency, the symptoms and the signs are based on the deficiency of each hormone. So if you have aldosterone deficiency, you tend to have your electrolyte and your volume regulation is involved. So because of that, you have hyponatremia with hyperkalemia, because the absorption from the kidney is affected because of your aldosterone deficiency. And if you have cortisol deficiency, you mainly have your decrease in energy reserves, which can lead to fatigue, which can lead to weight loss. Apart from that, you can have hypoglycemia. So that is another important presentation. And apart from that, because of your androgen deficiency, you can have, if it is a chronic adrenal insufficiency, you can have loss of pubic hair, loss of axillary hair, and you can have decreased libido. And apart from that, cortisol deficiency, and if you have adrenal medulla involved, then you can have hypotension also. So these are important to know. So the main differentiating factors between primary and secondary and tertiary are somewhat similar. So primary and secondary and tertiary is aldosterone, as I had already mentioned. So you can have clinical features such as hypotension and salt craving in primary, and in secondary, it is not usually present. Hypotension can occur in secondary also. That is because of your cortisol deficiency, which can lead to your hypotension. Apart from that, you have glucocorticoid deficiency, which is seen in both because it is under the control of the HPA axis. And glucocorticoid deficiency will lead to weight loss, anorexia, muscle aches, weakness, and gastrointestinal, so on and so forth. Apart from that, the androgen deficiency is mainly seen only in primary adrenal insufficiency, not in, and it's also seen in secondary. So because again, the androgen is controlled by the HPA axis. And finally, you have, because of the elevated ACTH, you have hyperpigmentation, which can be seen in primary and not in secondary. Apart from that, you have various other clinical features, such as you can have dermatological features. Apart from hyperpigmentation, you can have dry skin, and you can have hematological changes. You can have normocytic, normochromic anemia. You can have eosinophilia. And then apart from that, you can also have depression, fatigue, and decreased libido. So again, all these symptoms are very non-specific. So it is when a patient comes to you with these, it is very difficult to diagnose sometimes. Even if you do you might not get time to check for a postural drop. You might, when you do the electrolytes, it might be normal if it is just a mild adrenal insufficiency. So you might do a cortisol also, it might be normal. So that is again, in the next talks they'll tell you about the dynamic testing and all. I'm sure Dr. Arindam will talk about that. So this is why it becomes more and more difficult to diagnose these things. So we need to have a high index of suspicion. So when you're talking about hyperpigmentation is seen around maybe 40 to 70% of the patients with primary adrenal insufficiency. And the problem is in Indians, in Indians, because we are more darker skinned, we tend to miss it. And it's usually seen in sun exposed areas such as the knuckles, your palmar creases, if you have old scars, nipples, mucosal membranes around the oral mucosa, vaginal and vulval and anal mucosa. So why does the hyperpigmentation occur? Because of the excess ACTH. The excess ACTH goes and acts on the melanocortin 1 receptor. And this is what leads to hyperpigmentation. Earlier, there was a school of thought that it could be because of the POMC, which is again broken up into alpha MSH, melanocortin stimulating hormone. But newer studies have shown that this is the exact mechanism why hyperpigmentation occurs. Again, so the thing is, depends, the hyperpigmentation will be there or not depending on how fast the onset of your adrenal insufficiency is. Because suppose it's because of an adrenal infarction or a hemorrhage, you will not have hyperpigmentation because it is an acute event. If it is a long-term chronic adrenal insufficiency, you can tend to have hyperpigmentation. So apart from that, the other important causes are autoimmune and autoimmune polyglandular syndrome. So autoimmune is now the most common cause of primary adrenal insufficiency, and it has overtaken the infections also. In India, maybe infections and autoimmune may be somewhat equal, but I'll say autoimmune is still more common than infection. Infections mainly tuberculosis, fungal infections, histoplasmosis, cryptococcosis, and HIV. So these are the important infections. Apart from that, we have infiltrations, that is amyloidosis, hemochromatosis, and sarcoidosis. Metastasis, adrenal metastasis tend to be bilateral, mainly from your lung CA, breast CA, and malignant melanoma can cause. And there are certain drugs which like ketoconazole, metotane. These are actually drugs which are used for treatment of Cushing's syndrome. So those can also lead to adrenal insufficiency. Apart from that, you have phenytoin and barbiturates. And then there are some rare genetic causes, like you have your congenital adrenal hyperplasia, congenital adrenal hypoplasia, adrenoleukodystrophy, and some familial glucocorticoid resistance syndrome. So these are some rare genetic causes. If you're looking at secondary adrenal insufficiency, again, it could be similar to primary, such as infections, infiltration, irradiation, head injury because of some road traffic accidents, cellular and supracellular SOLs, and you have genetic causes like multiple combined pituitary hormone deficiency, and finally you have your pituitary apoplexy. The one which I missed in the secondary is, I've mentioned it in the tertiary. The most common cause is chronic steroid overuse or steroid maluse. So these things are the ones which are most commonly we see in daily practice. That is the steroid overuse leading to adrenal insufficiency. So when the patients present to us, they might be having features of Cushing syndrome, and because of the adrenal overuse. But when they will, because they have stopped the steroid use suddenly, they will tend to have a adrenal insufficiency. And rarely SOLs in the hypothalamic region and septo-optic dysplasia can also cause tertiary adrenal insufficiency. So again, so when you're looking at a patient with adrenal crisis, that is acute adrenal crisis, there are certain ways that people can present. So patient might already have a background of chronic primary or secondary adrenal insufficiency, and then added to that, you have a major stress, like maybe a major sepsis, you have a major surgery. So that is on the background of a known chronic primary adrenal insufficiency or secondary adrenal insufficiency. Apart from that, you have an undertreated, your patient is already known to have it and you are not treating it properly. So inadequate dosage of your hydrocortisone and fludrocortisone can lead to adrenal crisis. Apart from that, I already mentioned acute adrenal gland and pituitary hemorrhage or infarction. So this patient will not have the typical features. They'll suddenly present, if it's your adrenal gland infarction or hemorrhage, suddenly they'll present with abdominal pain, sudden hypotension. They might have fever, sudden hypotension, and shock. If it is a pituitary apoplexy, suddenly you will have severe headache, blurring of vision, and ophthalmoplegia. So you will not have typical features. And apart from that, again, people who are already on steroid use, chronic steroid intake, if you are improperly withdrawing glucocorticoids, then you can tend to have adrenal crisis. And they will have features of Cushing's, who will present with adrenal insufficiency. So when should you suspect this crisis? So again, they will be in shock. They'll have hypoglycemia, hyponatremia, hyperkalemia, and metabolic acidosis. And when a person comes, the important clues that tells you it could be because of adrenal cause is when you have this presentation with a history of fever. Patient has a history of autoimmunity, like other conditions. Maybe if the patient has Graves' disease, autoimmune thyroid disease, type 1 diabetes. So patient has premature ovarian failure. So these might be some small clues which might help. Then specifically, you need to ask for steroid use in the past. So steroid use in the past will lead to secondary and tertiary, as I mentioned earlier. So that could be due to herbal medications, Ayurveda, homeopathic medications. If the patient has had a road traffic accident or a head injury, again, with this presentation, you need to have a strong suspicion. History of coagulopathy, DIC, thrombosis, all these things can again cause adrenal hemorrhage and pituitary apoplexy. And if a patient has a history of cancer also, then you need to, such as especially lung cancer, breast cancer, malignant melanoma, all these things can lead to adrenal crisis. So autoimmune adrenalitis, the main pathophysiology is because of your 21 alpha hydroxylase antibodies that occurs because of the auto activation of the reactive B cells, which acts on the adrenal cortical cells, which leads to their destruction. Okay, so that is how the main test that we do for it is 21 alpha hydroxylase antibodies, but that is not easily available. Autoimmune adrenalitis is now the most commonly seen in females, and majority of the time you will have also other autoimmune diseases along with your autoimmune adrenalitis. So usually it can be along with that you'll have APS1 or APS2, that is autoimmune polyglandular syndrome 1 and autoimmune polyglandular syndrome 2. So you need to look for other autoimmune diseases associated with that. So in APS1, you need to look for oral mucocutaneous candidiasis. So that is important to look for. Apart from that, you need to look for hypoparathyroidism, type 1 diabetes, and enteropathies, and also primary and secondary primary ovarian and primary testicular insufficiency. And also you need to look for type 1 diabetes. So these are important other autoimmune conditions you need to look for when a patient presents with autoimmune adrenalitis. And now coming to tuberculosis. So tuberculosis can have a wide variety of presentation. It can present with both secondary and it can present with both with primary also. Primary, it can affect, it can be an acute presentation, which is within 2 years of an infection with tuberculosis, which can be a pulmonary or a extrapulmonary tuberculosis. And it can also be a chronic presentation over many years. So usually if it is a chronic presentation, you in your imaging, you might have calcifications, you might have granulomas, all those things you can see if you're doing a histopathology. So that I think the next speakers will be talking about. And tuberculosis, again, it is more common in males compared to females. And again, the mean, it can come at any age, but the mean age of presentation will be around 30 to 40 years of age. And there will be evidence of other extraadrenal tuberculosis in around 55% of the people. So I'm just summarizing. So adrenal insufficiency, again, it is very non-specific. Most of the time, most patients come with chronic adrenal insufficiency. So we need to have a strong suspicion, especially people who have high risk, like the ones which I mentioned earlier. And again, all the presenting features will depend on how fast they're presenting or how slow they're presenting and the extent of adrenal function loss. So I'm going to end my talk here. Thank you.
Thank you very much, Dr. Valsaraj, for your time and so beautiful presentation. So due to some lack of time, we will take the questions in the chat box, and may I request you to stay with us, and you can address those in the chat box if it is possible for you, and then we can start our next session. Okay.
Sure.
So once again, thank you. Now we are moving to our next topic, and our next topic is very important. That is Addison's disease, early diagnosis and clinical approach. So for that, on this topic, we have Dr. Arindam Ray, who is a prolific speaker in Kolkata in the field of endocrinology, and he is now assistant professor, Department of General Medicine in the College of Medicine and Sagar Datta Hospital, and he is also a visiting consultant of endocrinology at Zenith Super Specialty Hospital. So he had many publications. So we are really fortunate to have Dr. Arindam Ray, who is a very young and dynamic endocrinologist in the city. So over to you, Arindam da.
Thank you. Thank you for a kind introduction, Dr. Shambhu, and thanks for giving me the opportunity. Thanks, Indian Pharmacological Society. At the same time, Dr. Shambhu, for inviting me as a speaker. And a special thanks to Dr. Rahul Valsaraj, because, so my screen visible?
Yes, it is visible.
Yeah, okay. So just for giving a beautiful lecture on, and especially did a great job to reduce my burden of, the special slides, particularly the symptoms part. So my topic for today's discussion is early diagnosis and clinical approach. So here, as already introduced as the Addison disease, that's the primary adrenal insufficiency, and especially tell about this primary adrenal insufficiency, because secondary and tertiary as already to some extent elaborated by Dr. Rahul. Here, the first to say about Addison's disease, this is the father of endocrinology, Thomas Addison. At the year of 1855 in the Guy's Hospital, London, he first described this the symptoms and the signs in a very brief way, so that it will very very important to listen for the listeners, that how a patient of Addison disease first can be detected early. So what he has written in his paper, the discoloration pervades the whole surface of the body, but it's commonly most strongly manifested on the face, neck, superior extremities, penis, scrotum, and the flexures of the axilla and around the navel. The leading and characteristic features of the morbid state to which I would direct your attention: anemia, general languor, and the debility, remarkable feebleness of the heart section, irritability of the stomach, and a peculiar change of the color of the skin occurring in connection with the disease condition of the suprarenal capsules. So this is in brief what the Addison disease is. So why there is so much delay in the diagnosis of this Addison disease? Some points have been definitely elaborated by Dr. Rahul, because it's a rare disease. How many of us, when a patient presents with a pain abdomen, fatigability, we think about this Addison disease? Definitely, we first think about the acute gastritis, pancreatitis, some liver disease, some abdominal issues, some surgical issues. But definitely, the Addison's disease comes in the differential diagnosis in the list. So this is one of the very major issue that we have to take into account. What are the symptoms and signs when a patient presents, particularly with the hyperpigmentation? Definitely we have to think about this Addison's disease. And the overlapping symptoms, I've already told, these are the symptoms that actually manifested in different diseases of different systems. So particular for the Addison disease, the very specific the symptoms and signs are not there. So when we think about the bird's eye that is actually required for the diagnosis of this Addison's disease, very close differential diagnosis of this overlapping symptoms that lead to this diagnosis is very difficult to some extent. At the same time, the lack of laboratory facilities, particularly in the rural areas, in the peripheral areas, because I have seen one patient, 1 year back, when somebody was also suggested to do a serum, the morning cortisol to patient who presented with anorexia, pain, abdomen, and hyperpigmentation, lethargy. But in that area, that cortisol assessment was not feasible for the patient. He has to come to in the city Kolkata, which is too far from his residence. So that was delayed at least for 6 months or 8 months, when the patient actually presented in the hospital with, the addiction crisis. So these are the usually the lacks or the concerns that we have that makes the diagnosis of the addiction disease a delay. So early diagnosis is definitely one of the very major issue. Now, what are the symptoms and, to some extent the signs? The adrenal insufficiency usually presents with the fatigue, the weight loss, postural dizziness, the anorexia, abdominal discomfort is there. Hyperpigmentation, as already elaborated, particularly in the sun-exposed areas in the skin creases, the mucosal membranes, the scars, particularly the new scars. It's very important to differentiate it with the new scar, because old scars do not have the hyperpigmentation, whereas the new scars will definitely have the hyperpigmentation in the areolar area of the breast, at the same time the nipples. The low blood pressure with the increased postural drop. And what we do, how we actually check this postural drop, we actually measure the blood pressure in the supine posture, and at the same time, after 3 minutes of standing, we measure the blood pressure. So here there is a drop of the systolic blood pressure more than 20 millimeter of mercury, or the diastolic blood pressure more than 10 millimeter of mercury. That defines the postural hypotension or the postural drop. At the same time, the failure to thrive in the children, also very important, the signs for the adrenal insufficiency. When the patient presents with the adrenal crisis, it's a severe weakness, the syncope, abdominal pain, nausea, severe vomiting, that mimics actually the acute pain abdomen. At the same time, the back pain, confusion, many of times the patients have to be admitted with the dehydration. At the same time, the acute kidney injury and a lot of electrolyte abnormalities in the ICU. Then the patients at the same time have the hypotension, abdominal tenderness, GERDing, at the same time reduced consciousness and delirium. So these are the different pictures for my patients with the adrenal insufficiency. You can see the over mucosal hyperpigmentation in different areas. At the same time, this is a picture from a patient of Dr. Shambhu Shamazda, who has just shared few weeks back. So this patient also had the similar, the addition and insufficiency presentation. So the areas of the knuckles that are, also sometimes the creases of the palmar creases that are hyperpigmented in these patients. Now, it's very important that the autoimmune disease of the autoimmune adrenalitis is very important cause of this primary Addison insufficiency, in particular the Western countries. And the association with the other autoimmune diseases like the thyroid disease is a very common association with this autoimmune primary adrenal diseases. Now, we can see when usually the primary adrenal disease is autoimmune, there is actually 50% association with that of the autoimmune thyroid disease. Whereas in the reverse side, we can see if the patients actually have type 1 diabetes, or the patient have primary hypoparathyroidism. So in that case, the autoimmune adrenal disease usually very rare. It's association of only 1 or 2%, whereas a 16% patient of primary hypoparathyroidism may be associated with the autoadrenal antibodies. But the autoadrenal antibodies may not be evident in many of the patients, but when they are evident, so that actually signifies there is a chance of adrenal crisis in the next 5 years to the extent of 40 to 50% of the patients. So otherwise, in the patients of type 1 diabetes mellitus, the pernicious anemia, the gonadal failure, these are common associations with this autoimmune adrenal disease. So what are the laboratory evidence that actually suggest the patient may have the Addisonian disease? So this is the complete blood count where we can get the normocytic normochromic anemia, we get the eosinophilia, and also relative lymphocytosis. So these can actually give rise to the picture of the Addisonian patient. At the same time, the prerenal azotemia, the electrolyte abnormalities are very common, where the hyponatremia usually patient in 90% of the patient, hyperkalemia in 65% of the patient, at the same time the hypercalcemia in 6% of the patients, and hypercalcemia is usually associated with the patients also with the thyrotoxicosis associated with Addison's disease. At the same time, the metabolic acidosis with this hyperkalemia is a very common association. When there is a thyroid disease patient, usually the patients have the autoimmune hypothyroidism or the hyperthyroidism. At the same time, the anti-TPO positivity give you the clue for the same. Now coming to the direct, the blood biochemical test that actually give you the clue for this or this Addison's disease, that is the cortisol assay. So what we do is a serum cortisol assay. We all know that a cortisol is a hormone that actually have the diurnal variation. There is maximal, the cortisol secretion in the morning hours, and as the day progresses, particularly evening and night, that actually goes down. So comes to the Nadi value. So this is the diurnal variation of the cortisol. So if we have to prove the patient have the hypoadrenalism or hypocortisolemia, that time we have to do the blood test in the morning hours, when actually in physiologically the cortisol level should be at the highest level. So 8 AM cortisol is usually advised, but the timing of sample collection, what we say actually is the 8 AM to 9 AM. So anytime in between the 8 AM to 9 AM, we have to collect the blood sample. The assays are different. We can test it in different ways, like the ELISA, like the chemiluminescence method, like the electrochemiluminescence method. At the same time, the LC-MSMS, that is a liquid chromatography. But the cutoffs are actually also different from laboratory to laboratory, from methods to methods. So we have to check for the laboratory specific and also assay specific reference range for the cortisol assessment to say. And that is why usually the cutoff values for the diagnosis of this Addison's disease, or the patient to say that the patient have the normal cortisol, is actually varies, and that actually also very difficult many a times to say. The different studies that actually suggest if the cortisol, morning cortisol, the 8 AM cortisol value is less than 5 microgram per DL, then we can say the patient actually have the hypocortisolemia, or the patient have primary adrenal insufficiency. But what is the normal value of cortisol to make the cutoff? Then it's very difficult. There are different studies that actually says that starting from a value of 10.3 to 17 micron per liter, that actually defines whether the patient may have the normal cortisol response. Now coming to the patients who are in crisis. So when a patient comes to the crisis in the emergency, so that time the cortisol assessment is not mandatory. We have to give the treatment to the patient first, and before giving the hydrocortisone injection to the patient, we have to draw a random cortisol with a random ACTH of the patient, so that we can assess it later and start the treatment as early possible. Otherwise, random cortisol assessment usually do not have a diagnostic importance. So now coming to the short synaptic test, the corticotropin CST, that is actually short synaptic test, a very important test for the diagnosis of this Addison's disease, and is one of the gold standard to be taken as. Now, what is the principle when the adrenal cortex is usually functioning? What is the maximal stimulation from the ACTH that goes in the adrenal cortex, and that gives the maximal response in the serum cortisol level. So if the adrenal cortex is atrophied, then definitely the ACTH will not work here properly, and the cortisol level will not go in a peak after the certain duration. So here the procedure that we do is usually the intramuscular or the intravenous, the ACTH we inject. And here the dose, usually what traditionally we do is the 250 microgram of the synthetic ACTH that we inject to the patients. And the sample collection usually done at the basal, that is a 0 and the 30 minutes and 60 minutes. And definitely the interpretation will be, if the peak cortisol at any of this, the 30 or 60 minutes more than 18 micron per DL, then definitely the patients have the normal cortisol response with the ACTH, and we can exclude the cortisol, the primary adrenal insufficiency in these patients. But there are different caveats are there in of this short synaptic test. Here we can say that with the patient, the cortisol actually have two binding proteins, that is a cortisol binding globulin and albumin. So cortisol binding globulin and albumin that actually differs in different situations, like inflammation, where actually cortisol binding globulin level that decreases. The free cortisol level that increases, and the total cortisol level that goes down. Whereas in situations like the patient in estrogen formulation, so the patient in pregnancy, so in that case the cortisol binding globulin level increases. So in that case this gives the false positive result by giving the high total cortisol level. In situations like nephrotic syndrome, chronic liver disease, then also the patients will have a low cortisol because of the globulin or the albumin levels that decreases. So there are different controversies are there in this short synectin test, that the different preparations are there in the formulations that we have, what we inject. Here the ACTH, that is actually, the physiological ACTH, that is 139 amino acid. But what we have in our hand, that is the synactin, that is the tetracosaccharide, that is the 124 amino acid, the first 24 amino acids of the physiological ACTH. Now, what we have in our hand is another, the porcine ACTH, that is also known as actin prolongatum, that is again 39 amino acid. At the same time, the cosintropin, that is the tetracosaccharide, is also available in 24 amino acids. So this is the study conducted by Dr. Vilash Nair at Trivandrum Medical College, that actually, the validating study between this actin prolongatum and the cosintropin, that is the short synectin test, because the actin prolongatum, though it is used in different centers, but actin prolongatum is not validated against this short synectin test before the study. So whether we can use this actin prolongatum because this cosintropin or the tetracosaccharide is not so much available, particularly in India. Even a few months back, now by pharmaceutical like Sun Pharmaceutical actually brought this Sintropac, that is the cosintropin injection, but now it's available to some extent. But even a few months a year back, this was not so widely available, particularly in our student days. So we can do it, whether we can do it with this actin prolongatum, this was really a question. So this is a study conducted by Vilash Nair and his team. So what they have done, they have injected this 0.5 ml of that is the 30 units of this actin prolongatum intramuscularly to deltoid, followed by venous sampling of the serum cortisol at 60 minutes and 120 minutes. A dose of 30 units was chosen to ensure the ease of dispensing from a 300 units in 5 ml formulation, and stimulated peak cortisol cutoff of less than 18 on the SST was considered as adrenal insufficiency based on the guideline recommendation. So this is the result of the study that they have taken actually 47 candidates in whom first they have done the SST, that is a short synectin test, and out of them the 20 candidates diagnosed as adrenal insufficiency. Out of them 4 were primary adrenal insufficiency and 16 were the secondary adrenal insufficiency, whereas the 27 were taken as the normal or the patient do not have the adrenal insufficiency. In this category of adrenal insufficiency patient, after 3 days they have done this APST, that is actin prolongatum stimulation test, and the study result they have actually revealed that this two data are almost comparable, the SST and APST, and you can see the difference is not so much in these two cohort of the patients. So particularly from this study, they have concluded that the actin prolongatum stimulation test is almost comparable to that of the short synectin test. So what from the study result, they have concluded that 120 minute APST result that actually shows a best cutoff specificity is 19.5, whereas the sensitivity of this is around 100, whereas the specificity 88% when the cutoff at 120 minute APST is taken as 19.5 microgram per DL. Now the controversy too, that is whether we can do it with a high dose or low dose. There is some of the studies also shown that not the 250 microgram with a low dose, even with the 1 microgram after dilution, we can do this short synectin test. But the 2015 this Endocrine Society guidelines, they have actually concluded that although the low dose and high dose this corticotropin stimulation test yielded comparable result in the diagnostic workup of this primary adrenal insufficiency, and the low dose test adds no further sensitivity specificity over the high dose test, evidence have been presented that the low dose corticotropin stimulation test provides a higher sensitivity in the diagnosis of secondary adrenal insufficiency than the high dose test. But for the primary adrenal insufficiency, it's very clear there is no difference between this high dose, that is a 250 microgram, versus a low dose, that is a 1 microgram corticotropin stimulation test. So that is a conclusion for the primary adrenal insufficiency, because with the 1 microgram the CST actually is very difficult to do because the dilution is very difficult, number one. Number two is the administration of this very low dose low volume of this corticotropin is very difficult for the candidates. At the same time, the preservation also very difficult, though they have mentioned that it can be preserved at 2 to 8 degree with in the for the 60 days. But it's also the chance of contamination because of the dilution is also there. So a lot of the technical difficulties are there with this low dose test, and also 250 micrograms this corticotropin stimulation test, that is a high dose, is already validated. So it's better to do high dose test in particular for this primary adrenal insufficiency. But they have suggested that the low dose, that is 1 microgram corticotropin test for the diagnosis of this adrenal insufficiency only when the substance itself is in short supply. So definitely this requires more study, particularly in Indian subsets where corticotropin availability is really poor matter, where we can do this low dose corticotropin test. Now coming to the other test, apart from the SST or the CST, that is the insulin tolerance test. Here the mechanism of the principle is almost similar, that if the adrenal cortex is intact, with the hypoglycemia, we can see the patients have the excess cortisol secretion as so it is very important that if the patient are injected with the insulin and patients are rendered the hypoglycemia, so definitely the cortisol response will be at the highest of the peak if the patient have intact this HPA axis, that is hypothalamic adrenal axis. So it's one of the test that actually determines not only the adrenal axis, or rather the hypothalamic pituitary adrenal axis that is is intact. That is the result of this insulin tolerance test can say. So here the contraindications they are like if the patient have any convulsion disorder, if the patient have any severe ischemic heart disease, or the patient have severe this adrenal insufficiency, like severe hypocortisolemia, if the patient's particularly the morning cortisol level is less than 6.5 microgram per DL. So definitely we have to avoid this insulin tolerance test. So here we actually, after admission to the patient, definitely we have to give the 0.1 to 0.15 unit per kg body weight of insulin, regular insulin intravenously, and we have to draw the blood glucose sample at the same time the cortisol, the serum cortisol assay, that is 0, that is a baseline, and in every 15 minutes, that is 15, 30, 45, 60, and 120 minutes. And here we can see the maximal cortisol response, that is more than 18 microgram per DL, that is we think of with it's a normal condition. So that is the interpretation of this ITT. If it's less than 18, then definitely the patient may have this adrenal insufficiency or the hypocortisolemia in significance. Now coming to, there is also role of this plasma ACTH. If the SST or CST cannot be done, then definitely the morning cortisol, that is the 8 to 9 m cortisol with the paired plasma ACTH assay. Again, the ACTH assay, the interference is there at the same time. The reference range is also laboratory specific and assay specific. So the population based reference range is not there particularly for our part of the world. So the ACTH assay a bit difficult, but what the Endocrine Society guidelines suggest that ACTH level of more than 2-fold of the normal normative data, that's actually can be taken as significant. Usually in primary adrenal insufficiency, the ACTH levels are in 1000, but I have seen many of the patients are also 150, 200. That's the level of the ACTH that also associated with this primary adrenal insufficiency. The other test, like the overnight methylapone test. So what the principle behind this is, because we all know that methylapone is a drug that actually inhibits the cortisol synthesis. So what we do here, we give the 0.3 milligram per kg body weight of this methylapone at the midnight to the patient, and in the next day morning we collect the sample for the serum cortisol and the 11 deoxycortisol we assay. So here we what is the test result shows, that is with methylapone actually works on the serum, the adrenal cortex, that decrease the serum cortisol, but that actually increase the ACTH level, and here the ACTH actually increase the production of 11 deoxycortisol. So 11 deoxycortisol level rise where the cortisol level is low in presence of high ACTH. So that is the significance of this methylapone test, and that signifies it's a primary adrenal insufficiency, not the secondary one. The other stimulation test like CRA stimulation test is also there, which actually also defines differentiate the primary versus secondary. So with the CRA stimulation, Also, we can differentiate with the tertiary this adrenal insufficiency. So here in tertiary adrenal insufficiency with the CRH stimulation, the ACTH level will gradually high, and that will increase the cortisol in a gradual way. At the same time, the plasma renin and aldosterone assay definitely, as already mentioned by Dr. Rahul, that some of the diseases also that actually involves this primary adrenal insufficiency that actually involves this plasma renin. So plasma renin activity or concentration that goes high with the inappropriate low or normal plasma aldosterone level. But there is some issues with the milder form of the this congenital adrenal hyperplasia that forms the salt crisis, in particularly in the infant or childhood age, and the familial glucocorticoid deficiency where the ACTH mutation, ACTH receptor mutation is there. So in these situations, maybe the plasminogen aldosterone assay may be misdirectional for the diagnosis of this primary adrenal insufficiency. Now coming to the different, I'm sorry for the spelling mistake, it's the etiology of this primary adrenal insufficiency. For children, for infant, particularly the congenital adrenal hyperplasia with a 21 alpha hydroxylase deficiency is a very important cause of this primary adrenal insufficiency. It presents with the salt crisis. The autoimmune diseases, particularly autoimmune adrenalitis, is very common, but for the adults in the Western population, so antibody to 21 alpha hydroxylase is very important to diagnose, but in majority part of the world, including in our setup, this antibody detection is not so easy. So definitely here we have to go for this some of the expectations that in future we can have this antibody assay. At the same time, with the children, and the APS1, that is a autoimmune polyglandular syndrome 1, when the patient have the hypoparathyroid, at the same time the mucocutaneous candidiasis, along with this the additions in this particular patients, that is the at the same time we can call it as APECD, that is also associated with candidiasis and ectodermal dysplasia, along with that is the autoimmune polyendocrinopathy. Where also APS2, that is another form of this autoimmune polyglandular syndrome, where this hypoparathyroidism is usually as a this addition is usually associated with type 1 diabetes, at the same time hypogonadism and hypoparathyroidism. The adrenoleukodystrophy or the adrenal myeloneuropathy, that's another variant of this this primary adrenal insufficiency, particularly in the younger generation, and that usually presents in 2 to 10 years of age, where the autoimmune cause is not evident. Also, to some extent, adults where the myeloneuropathy is more predominant, where we can see usually the patients with the convulsion as in the peripheral neuropathy. And here we can see the change, the increase in the serum value of this very long chain, the fatty acids. So here the assessment of the very long chain fatty acid, particularly the non-immune cause of this primary adrenal insufficiency, very important when the patient actually presents with some neurological manifestations. So this is the slide that shows the imaging. Definitely for the etiology, we have to do some imaging when there is non-immune cause we are thinking of. So here the CT scan, that is the of the adrenal, is very important. In the first picture, we can see the calcification of the subcapsular region, and that suggests the histoplasmosis of the adrenals. And here the infiltrative disease is mostly there is adrenal enlargement. Whereas in the second picture, we can see the metastatic deposits, particularly here in the patient with this melanoma, malignant melanoma, where this this metastasis are there, though metastasis from the lungs and the breast, particularly very important for the adrenal point of view. The third, the patient actually have the C picture that actually shows the adrenal hemorrhage, particularly the patient on the low molecular weight heparin, but for the deep vein thrombosis. And the fourth patient is in that adrenal tuberculosis, where in the initial states of the adrenal tuberculosis, where there's adrenal enlargement is there, but with the due course of time, with the treatment, particularly with the anti-tubercular drug, we can see the fibrosis and calcification. And here particularly we can see the calcification of the adrenal gland with this after the adrenal tuberculosis. So this is the last slide of my presentation, showing how to approach the patient of primary adrenal insufficiency. So if the patient are infants, selected children, adults, the 17-hydroxyprogesterone is very important. So if the 17-hydroxyprogesterone report goes in favor of this age, that signifies its importance. If it is negative, then genetic analysis we have to do for the idiopathic PI. For the subjects with more than 6 months of age, then 21-hydroxylase antibody for this autoimmune adrenalitis is very important. And if the patients are present, if the antibodies are present, then autoimmune adrenal disease, then APS1, APS2, we have to consider. But it's negative, then CT adrenal we can do for the infiltrative disease, adrenal hemorrhage, infections, at the same time the malignant tumors. Here, we can say that this candidiasis, histoplasmosis, at the same time the cytomegalovirus infiltration with this adrenal disease is very important, particularly nowadays in the immunocompromised patients with the HIV positive patients. And patient on 20-hydroxylase antibody negative, again we can do particularly for the males the very long chain fatty acid level in the serum for the adrenoleukodystrophy or the adrenomyeloneuropathy. So that's all from my side. Thank you for your kind listening.
Thank you, Dr. Arindam, for your beautiful presentation. So there is 2 questions. I think we can address those 2 questions, and then we can move forward to the next topic. So first of all, the question asked by Dr. Amitavo Bosu, that hypothyroid patients with high anti-TPO level should be tested for Addison's disease routinely, and what instruction to be given to laboratory staff for preservation of blood sample for ACTH assay?
The first thing is that the hypo, as already I've mentioned in my slides, that the association with other autoimmune disease like type 1 diabetes, autoimmune hypothyroid, usually the association with the adrenal Addison's diseases chance is 1 to 2%. So it's a very rare association. If the patient have the clinical features that suggest the additions like the hyperpigmentation in different parts like the knuckles, the oral mucosa, patient have postural drop, that is the orthostatic hypotension, or the patient have the features in the blood biochemistry, that's the patient have this hyperkalemia, particularly hyponatremia unexplained, then definitely we can think of these additions and we have to go for the serum cortisol. Otherwise, in all the patients of autoimmune hypothyroid, it's not necessary to do this screening for the Addison disease, that I say. And for the ACTH assay is very important because ACTH is a peptide. So as we routinely draw blood, it's not the routine procedure like that. So it's better to draw the blood in the laboratory when the patient is sitting in the laboratory, and we have to draw with a glass syringe that is pre-chilled, and at least we have to take the sample, and we have to the serum separation that should be done within 30 minutes of this sample collection. So these are the very important steps. Otherwise, we can have the false low value for the serum ACTH, because the serum ACTH is a peptide and that will be easily destroyed if it's not handled properly. So these are the instructions that is usually given for the laboratory technician.
Okay, thank you. And another question asked by Dr. Ranavir Homik, does injection steroids given as emergency measure for few days alter the serum cortisol level estimation done to arrive at a diagnosis?
Yeah, that has already elaborated by Dr. Rahul Valsaraj, that not only the duration of the corticosteroid treatment, but also the dose that is also very important. So if we give a high dose of steroid, even for a lesser days, then definitely we can have the alteration of the hypothalamic pituitary adrenal axis. But usually what we suggest a dose of the more than the physiologic dose of more than 3 weeks in any patient, we can have the suppression of the hypothalamic pituitary axis, adrenal axis. So if it's given for a longer duration, like in the topical corticosteroid, or the patient on inhaled corticosteroid in different meter dose inhalers, that also can have, even in the very low dose, that can have the this axis suppression. So it is not only the dose or duration, it's a combined effect. So for how many days we are giving, for what is the dose we are giving, that has to be very important. So if even say that 1 gram methyl prednisone is given for 7 days, definitely it will have some impact on the adrenal this cortical synthesis. So it's very important for the clinical situation per se.
Thank you. So we have to move now to our next topic, and that is the management of Addison's disease. And we are really fortunate to have Professor Anirban Majumdar, who we can say the teacher of teachers in the field of endocrinology, diabetology. And personally, I am really fortunate to be a student of him under one very important course he always taught every year, that is Integrated Diabetes and Endocrine Certified course, which is certified from the University of Newcastle, Australia. So sir is now professor of KPC Medical College and Hospital, Kolkata, in the Department of Endocrinology, also conjoint professor of School of Medicine and Public Health, the University of Newcastle, Australia. He is the fellow of Indian College of Physicians. And we are really fortunate to have sir with us today. Over to sir to talk on the management of Addison's disease.
Thank you, Shambhu, for your nice introduction. And I'm really fortunate to have this invitation and to talk about the this topic, which is very close to my heart. Is my screen visible, Shambhu?
Sir, yes, sir, it is visible and it is now full screen, sir.
Okay, thank you. So the issue of the adrenal insufficiency is not its a problem in the management, but a problem in the diagnosis. I have a lot of stories to share how the diagnosis of adrenal insufficiency is missed by the physician, is missed by myself. So what we need is the awareness among the physicians to identify the disease, because nobody will come to an endocrinologist or a physician that I have Addison's disease, please treat me. But the people do come to you that I have diabetes and please treat me. So therefore, unless and until we have the high index of suspicion, there is every possibility that will miss the diagnosis. Now, this is the how to proceed for the diagnosis is elaborately discussed by Arindam. So I am thankful for his beautiful deliberation. So I will concentrate on the management of the Addison's disease. And first of all, we have to address the etiology, if possible. Second, what we'll do as a long-term management. And third, and very, very important, is a prevention of crisis. That actually we don't teach we don't educate our patient. I believe it requires lots and lots and lots of education to our patient to prevent the crisis. Now, coming to the causes of the adrenal insufficiency or primary adrenal insufficiency, which is very nicely elaborated by the Rahul. I'm not going in detail, but just I would like to say that if you can identify the cause, then you have to address the cause of adrenal disease. First of all, if it is an autoimmune disease, there is a possibility, we are discussing the possibility of having another autoimmune disease. So be very careful if you're dealing with an adrenal insufficiency due to an autoimmune disease, careful that you are not missing another autoimmune disease. Second, there is a possibility of tuberculosis or fungal infection, which is common in our country. So possibly we have almost equal number of the this infectious adrenalitis and the autoimmune adrenalitis. So we do not want to miss them, because apart from the treatment of adrenal insufficiency, we have to give a treatment for tuberculosis or the fungal infection. And third, if you suspect it is a metastatic cancer, we have to search for the primary one quite naturally. I think you can understand very well. Look for the drugs which may have a contributing factor as far as the development of Addison's disease is concerned, and whether we can stop or withdraw that drug. So don't bother about the others. These are very rare. We don't have to discuss about this. So be very careful about this 4 variety, and that's all. Nothing more is required. Now, this is the polyglandular autoimmune syndrome, and we have 2 different subtypes. We don't have to go in detail, but only issue that we have to remember that if somebody is detected as autoimmune adrenal disease, we have to search for another autoimmune disease. That's it. The second important issue is that we expect if it is an autoimmune adrenal disease, the gland or the adrenal gland should be small. Adrenal gland should be of normal size. It cannot be big. So after the diagnosis, you will do a CT of the adrenal because it is a primary adrenal disease. And if you find that the adrenal gland is big, it means it is not primary. It is not because of autoimmune adrenal disease. There must be something else. It may be tuberculosis. It may be other granulomatous disease. Maybe fungus. It may be a metastatic. So whatever maybe it is, you have to find out the cause. So my first objective is that if possible, I'll find the cause of adrenal insufficiency. At least I'll give an honest endeavor to find out the cause of adrenal insufficiency. And then I will not only treat the adrenal insufficiency, but also treat the primary cause. Now coming to the long-term management. Now you have the autoimmune adrenal disease, as we can see in many patients. So there is nothing to treat about the primary disease, or you are already treating the primary disease. And at the same time, you have to correct the adrenal insufficiency. So what is the ideal glucocorticoid replacement regimen? We don't have. So the cortisol secretion is basically have a circadian rhythm, and no preparation actually can mimic this circadian rhythm exactly. So therefore, there is no ideal replacement. Second, that the inter-individual variability is there, and therefore correct dose cannot be predicted. As because there is an inter-individual variability, no cortisol preparation can give the correct dose. Dose titration is very difficult. We'll discuss, and easily monitor. Again, another very important challenge in front of us, because it cannot be easily monitored. In case of diabetes, you can monitor with blood glucose or HbA1c, but in case of cortisol replacement, very difficult. There is hardly any biochemical tool by which we can monitor the amount of glucocorticoid replacement. Now, this is the circadian rhythm. As you can see, the circadian rhythm for this cortisol secretion is basically have 3 peaks. As because it is a 3 peaks, so we will try to mimic the replacement therapy in such a way that it produces almost similar 3 peaks. We remember that at night the level is very low, even goes below the reference range. Number 1, and number 2, that the goes up just after waking. So the dose you have to give early in the morning, even before breakfast. And second is actually it starts rising before someone is getting up. Before you are waking up, the cortisol secretion start increasing. So that is an important challenge. Now we have the lot of glucocorticoid preparation. I think all of you are aware. We have this short-acting preparation hydrocortisone, which is the drug we most commonly use as far as the replacement therapy is concerned. When we were DM student at that point of time, hydrocortisone was not available. We had only prednisolone and dexamethasone. So we used to treat with dexamethasone and prednisolone, even though they had a lot of limitations. But nowadays, you are fortunate, we have the hydrocortisone available, and we can use this drug. We have prednisolone and prednisone that also we use, and also the dexamethasone. The other drugs are not usually used as far as the replacement therapy for the adrenal insufficiency is concerned. Now coming to the short-acting preparation. Now this is the hydrocortisone or cortisone. Now we don't use cortisone because there are some limitations of cortisone therapy. We give hydrocortisone. So how many times we should give? As you can see that there is a 3 important peaks as far as the circadian rhythm is concerned. So we will give it at least 2 or 3 times in a day. Whom should be given 2 and whom should be 3? No guideline. Now you can give twice daily. Sometimes some of the patient can have some symptoms in the evening hours. So we can divide the dose into 3. What is the dose? The total cortisol secretion normally in our body ranges between 15 to 25 milligram. And therefore, the replacement dose is 15 to 25 milligram, because the hydrocortisone, what we are using, is almost 100% absorbed from the GI tract. So so you don't have to give some extra dose because the 100% is not absorbed. We have to use the lowest possible dose which relieves the symptom. So when you are giving twice in a day, give 10 milligram, 5 milligram twice in a day. Usually we give 10 milligram after waking and 5 milligram in the afternoon. If we give the thrice daily regime, we give 10, 5, 2.5, total 17.5 milligram. So 10, then the 5, then the 2.5 in morning, early afternoon, late afternoon. Remember that the hydrocortisone has got some mineralocorticoid activity, not very strong, but have some mineralocorticoid activity. And therefore, if we're giving fludrocortisone, as many of our patients actually require fludrocortisone replacement therapy, which is a primary, so the dose may be slightly less. What are the disadvantages of this drug? Now, even though we are giving thrice in a day, even though they are short-acting preparations, these normal diurnal rhythm cannot truly be replicated. This is number one. And number two, I have told you that before getting up in the morning, the cortisol secretions start rising. But you have given the last dose in the late afternoon, and therefore there is no cortisol in the blood, and therefore in the morning hours, the patient can have fatigue, lassitude, nausea, and some early morning adrenal insufficiency symptoms. And therefore, that is an important limitation of these short-acting preparations. Now, when you are using long-acting preparation, yes, Prednisone Dexamethasone, you can give it. Now, this provides a smoother physiological effect, and marked changes in the serum glucocorticoid level will not occur, which is observed with the short-acting preparation. The standard dose is 0.5 milligram dexamethasone and 5 milligram prednisolone. Some of the patient may require slightly higher and slightly lower dose. As I've already told you, we will keep the lowest possible dose just to relieve the symptoms. And if you try to replace the full replacement dose, you are over-treating, and there is a possibility of development of Cushing's disease. This particular dose is a long-acting preparation useful if the patient are non-compliant with multiple daily dose, because the primary adrenal insufficiency is a lifetime disorder, and they have to take this twice daily or thrice daily preparation for the rest of the life. So it may not be acceptable to many of our patients, and therefore in those cases you can give the long-acting preparation. This is an added advantage that it will not have the severe late evening or early morning symptoms. So that is an important advantage. But at the same time, because it is a long-acting preparation, often the patients are over-treated and will land up into the Cushing's disease or drug-induced Cushing's symptoms and signs. Now, how to monitor? As I've told you, monitoring is the most challenging aspect as far as the corticosteroid replacement therapy is concerned. We use the lowest possible dose to relieve the symptoms. If you give high dose, there will be weight gain, facial plethora, and other symptoms and signs of the Cushing syndrome. You may measure plasma ACTH, but if the plasma ACTH is normal, it means that actually you are giving over replacement and the patient will land up into Cushing's. Normally, if you give hydrocortisone therapy, the plasma concentration of ACTH remains 2 to 8 times higher than normal. So don't look at the plasma ACTH value and don't try to make plasma ACTH value normalize. If you're trying to make the plasma ACTH value normalize, then you are actually over-treating the patients. So therefore, plasma ACTH value is not helpful. So we actually are left with nothing but the clinical signs and symptoms as far as the assessment of the adequate replacement therapy. Coming to the mineralocorticoid replacement, as I've told you, majority of our patients actually require mineralocorticoid replacement therapy if it is a primary adrenal insufficiency, as Rahul has already pointed out that if you are having the secondary adrenal insufficiency, you may not require mineralocorticoid replacement therapy. Now, usual dose is 100 microgram, but it may ranges between 50 to 200 microgram. But the issue is some of the patients are quite sensitive, and some of the patient may require 50 micron twice in a week. So be very careful. Unless and until required, don't give an extra dose. If you give extra dose, the patient will have hypertension. Now, in the summertime, some dose adjustment is required. Ask the patient to take liberal salt intake. But if the patient has got a coexistent primary hypertension, your dose requirement of fludrocortisone is low, and don't use diuretic, especially the spironolactone or triamcinolone, this kind of drug. Don't use diuretic. There is a possibility of adrenal crisis if you are using diuretic or spironolactone or these kind of drugs. So mineralocorticoids, as I've told you, rarely required in secondary adrenal insufficiency. Now, monitoring of mineralocorticoid replacement is much better than the monitoring option available with the glucocorticoid replacement. We can look for the symptoms: salt craving, intermittent nausea, we can look for the symptoms of postural hypertension. They are consistent with mineralocorticoid deficiency. On the other hand, if there is an hypertension, edema, or hypokalemia, this signs excess replacement. Potassium is a very good marker. Look at the potassium. If the potassium is low, it indicates excess replacement. If potassium is high, you are under replacing. So give some amount of fluid to cortisol. Even after full replacement dose of cortisol, if you find the potassium is on the higher side, it means the patient will require some amount of fluid to cortisol supplementation. The most important monitoring of the mineralocorticoid is done by the plasma renin activity. It is recommended that we should measure it once in a year, and we have to target that we have to suppress the plasma renin activity to the upper normal reference range, that is 1 to 4 nanogram per ml per hour. However, if a patient is asymptomatic and have normal potassium, that means there is no symptoms. There is no symptoms of postural hypertension. There is no salt craving. There is no nausea, and the patient has normal electrolyte. Even if the plasma renin activity is high, you don't have to adjust the dose. So don't try to normalize the plasma renin activity. So the issue is that again coming down to boils down to one point, that we have to take care of the symptoms for monitoring both the cortisol replacement as well as the mineralocorticoid replacement. Sometimes there is a requirement of androgen replacement. I don't have any personal experience of androgen replacement therapy in adrenal insufficiency, because the androgen deficiency usually occurs in female, not in male. You know, in case of male, the most of the androgen comes from the testis, and therefore in an adrenal insufficiency, the androgen is not deficient because the testis is normally functioning. On the other hand, in case of female, the majority of the androgen comes from the adrenal cortex, and very little comes from the ovary. And therefore, in primary adrenal insufficiency, when the adrenal gland is destroyed, so not only you have deficiency of cortisol, not only you have deficiency of mineralocorticoid, but you also have deficiency of adrenal androgen, and that is DHA. So dehydroepiandrosterone is basically deficient, and this androgen deficiency is more evident in women because they have no other source of androgen production. So in women with adrenal insufficiency, DHA is extremely low, and if you replace that DHA, it improves the mood, quality of life. But as we are more concerned about the sexual well-being of the women, because the sexual well-being of the women depends on the androgen. Even in the women, it depends on the androgen. But because the androgen is low because of primary adrenal insufficiency, there is a high possibility of sexual dysfunction, which is often observed among the women patients with primary adrenal insufficiency. But with DHS replacement, this sexual well-being is not corrected. That is an important limitation of DHS therapy. The replacement dose is 25 to 50 milligram. We start with 25 milligram, gradually uptitrated. The very, very important adverse event is the androgenic side effects, which can be observed in women because we are giving androgen. Sometimes it is given excess dose, and we have no way to monitor. And therefore, we are give arbitrary dose of 25 to 50 milligram. We have to look into the mood, quality of life, which is quite subjective. And therefore, the possibility of androgenic side effects is there. There is no universal recommendation that every patient will require this DHA replacement therapy. It is reserved only for those who have significantly impaired mood or sense of well-being despite optimal glucocorticoid and mineralocorticoid replacement. Last part is that we have to prevent the adrenal crisis. Now, I have told you that the education required. I have seen many patients whom we have treated. We have discharged the patient from the hospital with a thorough instruction to continue with the replacement therapy. A patient went back to his hometown or his village or her village, and he or she has developed some minor illness, say diarrhea or say respiratory tract infection or whatever maybe it is. The treating physician stopped the steroid because the steroid actually immunosuppression, and there is an infection. So say urinary tract infection, so you stop the steroid, and once the steroid is stopped, the patient landed up into the crisis. So we have observed many times this scenario. So I do not want to increase the awareness among the physician. Rather, I want to educate my patient that you see that if you develop this, you have to increase your dose. Don't stop for the rest of your life. So therefore, education of the patient is more important. rather than the physicians, because the physicians often do not understand the importance of continuing steroid replacement therapy for the rest of the life and the requirement of increasing the dose at the time of need. Now, if there is an illness, say for example, minor illness, respiratory tract infection, increase the dose to glucocorticoid 2 to 3 times in a day. It is 3:3 rule. It means you have to increase the dose 3 times for 3 days. If you find that your problem is resolved, it is okay, fine. If the problem is not resolved and if there is a worsening of this symptom, you need further medical attention, and that you have to convince the patient. And that is the point of education, that you treat yourself, increase the dose. If you feel that it is not improving, go to the hospital and get admitted, and whatever maybe it need further medical attention. With nausea and vomiting, if you are unable to retain the oral medication, means you are giving the drug to 2 to 3 times than your normal replacement dose, but you can't retain that, go to the hospital, because you need the intravenous or intramuscular glucocorticoid injection. The Ramadan is another important challenge. Ramadan has got a lot of challenges in among the diabetic subject. Ramadan also is important challenge in the primary adrenal insufficiency. Now the Ramadan is running, and one of my patients is actually doing fasting. So in primary adrenal insufficiency, when there is a Ramadan, the patient don't take anything during the day. So if the patient is on a thrice daily replacement dose, we can't give it. So we give the long-acting preparation. So give prednisolone or dexamethasone, whatever maybe it is. So prednisolone you have to give at the time of Sahari in the morning. Just give prednisolone 5 milligram at the time of Sahari. Second is that you have to give a clear instruction about the hydration sick day rule, and if the patient feels sick, he should urgently terminate his fast and then give an injection of hydrocortisone intramuscularly. We have to teach the patient how to inject hydrocortisone, self-injection of hydrocortisone. That is an important issue, and we have to educate the family member that if there is any such emergency, if there is the patient is feeling unwell during the fasting, he needs to be hospitalized or needs a medical attention, and urgently stop the fasting. In case of surgery, during the surgery, previously we used to give a very high dose of steroid therapy or under very high dose steroid cover. Nowadays we have a lot of data available, and on the steroid cover, the dose of the steroid cover has come down. Now, in a patient who will go for a minor procedure, the recommendation is that you just give 25 milligram hydrocortisone the day of operation. No point of doing anything. From the second day onwards, the normal replacement dose. Say, for example, going for herniorrhaphy, or going for a dental extraction, or going for a colonoscopy, or going for a cataract surgery. Give 25 milligram dose on the day of surgery. That's it. Next day onwards, replacement dose. In a moderate surgical stress, say cholecystectomy, joint replacement, you have to give hydrocortisone intravenously, maybe 50 to 75 milligram on the day of surgery, the first postoperative day, and from the third day or on the second postoperative day, usual replacement dose. In case of major surgical procedures, say for the bypass, previously we used to give 100 milligram 3 times in a day, and nowadays we give 150 milligram hydrocortisone divided dose. So 50 milligram 3 times in a day, or give 150 milligram intravenous infusion in a whole 24 hours for 2 to 3 days. And after 2 to 3 days, if everything goes all right, if there is nothing wrong and the patient is gradually improving, then return to the usual dose. Now, pregnancy is a very, very important challenge. I don't have any patient who is suffering from the adrenal insufficiency, primary adrenal insufficiency, and is planning for pregnancy. But the dose of glucocorticoid and mineralocorticoid replacement to be continued. No dose adjustment is required, except there is some suggestion that during the third trimester, some of the patient may require slightly higher dose. But the challenge is actually at the time of labor. Labor is basically a stressful situation, and therefore during this time you have to administer 25 milligram hydrocortisone intravenously every 6 hours. But once after the delivery, then you can gradually taper the dose to the maintenance dose within the 3 days. The mineralocorticoid replacement therapy during pregnancy is a controversial issue because there are no studies So we don't know, but we should give both the glucocorticoid and mineralocorticoid replacement during the whole period of pregnancy with the same dose. However, we need to check the electrolyte and signs of volume depletion and plasma renin activity. But be careful, plasma renin activity during pregnancy is at the higher level. So normal level during pregnancy is 20 to 25 nanogram per ml per hour. And therefore, if you want to monitor the mineralocorticoid replacement with respect to plasma renin activity, keep the value at the upper range of the normal with respect to the pregnancy. Now, how we can prevent the crisis? Number one, the steroid card that is conventionally advised as far as the Western recommendation is concerned. We don't have any emergency steroid card, but I usually give a printout on the back of my prescription that what the patient should do should they become sick. So this is a sick day rule. Sick day rule, as already I have discussed, that the need to double or triple the dose of oral glucocorticoid dose if the patient experiences any kind of fever, infection, dental work, anything. Second, if the patient has got severe illness, trauma, persistent vomiting, or a surgical intervention, the patient needs glucocorticoid intramuscularly or intravenous injection. The patient must understand. It is a patient responsibility to understand. And patient need to go to the physician to say that I need this injection if I am going through this procedure. That is what the doctor said to me. We have to explain them what is the rationality of this dose adjustment during sickness and during the stress, because many people will try to convince him that you have to reduce the dose or to stop the dose because you are suffering from infection. And during the infection, you have to stop the steroid. Otherwise, there will be immunosuppression. So quite naturally, this must be we have to convince the patient that you have to increase the dose, not decrease the dose. And as I've told you, teaching the parenteral self-administration of glucocorticoid preparation, and that is very important. And we have to advise the patient, go to the hospital if there is any emergency arises, and show the treating doctor that this is my prescription and I need glucocorticoid injection intravenously or intramuscularly. They must have sufficient supply of hydrocortisone. I usually advise all my patients keep a 1 or 2 vial of hydrocortisone. It is not very costly, so they can keep it with syringes and needle. And usually I advise them to self-inject. The leaflet for adrenal crisis and emergency phone number should be available to them. At least their treating doctor, treating physician, and they should keep all this supply with them and take it along with them when they are visiting a local physician or the local hospital, so that no time is lost for searching the availability of hydrocortisone injection. It is often not available in the remote areas. So every visit, there is nothing to do as far as the diagnosis comes. The diagnosis is already done. Patient is receiving the replacement dose. And every time when your patient is coming to you every 6 months or every year, you have nothing to do. The only one thing that we are supposed to do is to educate, reinforce the education, and confirm the understanding that they understood what they're supposed to do should the emergency arises. And that is the challenge. If the patient develop adrenal crisis, quite naturally, the response to the treatment is excellent, provided it is started early. So give good amount of saline to make the blood pressure maintain. Hydrocortisone, you have to give 200 to 300 milligram per day, and treat hypoglycemia if it is there with dextrose. These are the 3 issues: hypoglycemia, volume, and replacement of steroid, high dose steroid. That's it. Some of the patient may require cardiac monitoring, and rapidly taper the dose and shift the patient to oral regime on the basis of the clinical state. So see, I have some caveats as far as this talk is concerned, that only few and mostly underpowered short-term studies are compared different doses regime of glucocorticoid. So you can use any of the dose schedule I am talking about. And prospective studies comparing the safety efficacy of prednisolone and hydrocortisone over time are not available. And treatment of ACTH to guide glucocorticoid replacement, as I've told you, is not recommended. Increase in cortisol during anesthesia, surgery, trauma, critical illness with great inter-individual variation. So exact dose we don't know, but we try to cover the stressful situation, and we actually high dose glucocorticoid we give in surgery not to mimic the median value of normal subject, but to cover the additional needs if the complication occurs. So we try to give an excess dose to cover the acute situation. But nowadays, as we have a lot of data available, our dose has came down, not the replacement dose, but the dose for the acute management has come down, especially during surgeries. So take home message that the replacement dose of chronic adrenal insufficiency, hydrocortisone 15 to 25 milligram per day, and mineralocorticoid 50 to 200 microgram per day. Thrice daily administration closely mimics the day curve of cortisol. Use the lowest dose of glucocorticoid that relieves symptoms. Otherwise, patient will end up into Cushing's. DHS therapy only for those women who have significantly impaired mood and sense of well-being despite optimal glucocorticoid and mineralocorticoid replacement. Replacement dose is higher in critical situation, illness, surgery, pregnancy. Thank you very much for your patient listening.
Thank you, sir. Thank you very much, sir. So we can take one question, sir, and that is asked by Dr. Ashish Kumar Bosu regarding that HIV and glucocorticoid resistance in etiology and management accordingly. So we all know that there are some cases where glucocorticoid resistance happens in HIV patients. So your take on that, sir?
No, I don't see the HIV patient, but if the patient has got HIV associated glucocorticoid deficiency, so quite naturally the patient will be treated in the same manner, but however, some of the drug interaction may be there. So if it is there, some drug interaction, that the dose of glucocorticoid may be adjusted accordingly.
Thank you, sir. Thank you once again, sir. So we have, as we have very less time, and we have to move to our next topic. And for that, we have Dr. Shoibal Das, who is a clinical pharmacologist, and now he's attached with ICMR. So may I request Dr. Shoibal Das to present his topic on clinical pharmacological review of use of steroids in Addison's disease.
Yeah, thank you, Dr. Shambhu. Now I'll just share my screen. I hope my screen is visible.
There is some issue, I don't know, in the screen. You can change your slide so that we can see whether it is moving or not.
Yeah, can you see it now?
No. I think you have to reshare. You stop the screen sharing and you can reshare.
Yeah, I'll just do that. Is it coming?
It's coming, but you can you make it a full screen?
Yeah, I'm making it full screen.
So when you are doing it full screen, there is something happening in the screen.
Is it visible now? I have made it full screen.
No, that is I'm asking that when
Okay.
you are making it full screen, there is some issue.
Okay.
The screen is blocked like that.
1 second. In that case, let me try once more. Is it still blocked?
No, now it's okay. Now it's fine.
Okay.
Please.
So the slides are moving, right?
Yes. Moving.
Yeah. So thank you, Dr. Shambhu. Thanks for this opportunity. And we have had a great presentation lastly by Professor Majumdar, and he has elaborated about the treatment of Addison's disease. So we have learned about the treatment of Addison's disease in a lot, but as Sir has mentioned that there is no ideal glucocorticoid replacement and there is a marked inter-individual variability. So glucocorticoid treatment is also, as a result, not uniform or consistent. So a study has been done in patients enrolling from the European Adrenal Insufficiency Registry with a fairly large sample size of around 1,166 patients. And the study has shown that there is a significant heterogeneity in the type, dose, frequency, and timing of glucocorticoid replacement in the real world practice in patients with adrenal insufficiency. And this also reflects that dose individualization based on patient symptoms is essential. With this backdrop, I will try to present on the following topics. We will revisit the pharmacological actions of glucocorticoids, because we have now known that there is a lot of inter-individual variability as well as inconsistency in the prescription of glucocorticoid. So while we revisit the pharmacology, we will also revisit the different types of steroids and their therapeutic indications, in particular focus to Addison's disease. And since patients will be also on a long-term steroids, most of our patients are, so we have to understand, while we are talking about the clinical pharmacological aspect, we will understand the different glucocorticoid related adverse events and the key assessment and monitoring parameters, the major drug interactions with systemic corticosteroid use in these patients for a long time, and some of the management of these adverse events with glucocorticoid therapy. So just a brief summarization that while about the pharmacology of steroid, so we all know that it brings in around a plethora of changes, which also involve several metabolic parameter alterations, and the steroid therapy causes increased neoglucogenesis, increased glycogen storage, reduction of insulin secretion, increased proteolysis, reduction of glucose transport, increased lipolysis, and of course these are also coupled with increased bone resorption, and some of these are also related to the therapeutic uses of the steroid in conditions like having anti-inflammatory and immunosuppressive actions. It increased sodium reabsorption and potassium secretion, enhancement of vascular reactivity, as well as the stress reactivity regulation. So because of this plethora of dynamics of steroids, like the pharmacodynamics of the steroids, so the basic actions on a long-term steroid use are not only restricted in terms of the adrenal gland is concerned, because while we are giving the systemic steroids, so as a result, steroid also has with its own inherent properties of anti-inflammatory effects, immunosuppression, which is also the common case which are clinically encountered. And because, as sir mentioned, that while patients are having infections and because of immunosuppression, there is a therapeutic chance of that reduction of steroid, which should not be done otherwise. Also, there is anti-proliferative activity as well as vasoconstrictive activity. For the interest of a larger audience and for the sake of completion of this part, we will discuss about the different types of steroids while discussing this particular issue. And we know that steroids are both having particularly the glucocorticoids can be short acting, intermediate acting, and long acting, and hydrocortisone having the relative glucocorticoid activity of 1, and it also has the mineralocorticoid activity of 1. And with reference to hydrocortisone, we actually classify the other steroid based on their relative glucocorticoid activity and relative mineralocorticoid activity. So we have here hydrocortisone, prednisone, prednisolone, and even within the long-acting ones, we have dexamethasone, betamethasone. And we also need to discuss here about fludrocortisone, because many of the patients do need primary adrenal insufficiency, do need mineralocorticoid replacement as well. So while we use this steroid in the patients may develop a plethora of adverse events because many of them will be using for a long time, and patients may develop osteoporosis fractures, may have HPA axis suppression, and may have Cushing syndrome, may have hyperglycemia or diabetes. Other cardiovascular risk may increase because of dyslipidemia, myopathy, posterior cataracts, glaucoma, some psychiatric disturbances, immunosuppressions, even GI events, and dermatological events as well. So while we administer steroid to the patients for a long time, these are the common recommendations of checking or monitoring the patients routinely. At baseline, we need to monitor the basic physical within the physical parameters, weight, height, BP, BMI, and the labs counts, glucose, lipids, and the BMD also. And subsequent monitoring, again, the bone health is concerned, growth is important even in children. Then dyslipidemia, glycemic status, and routine ophthalmological examinations. Many of the patients will be having concomitant diseases and illnesses, and maybe also on different other concomitant pharmacotherapies. So it is to understand the common pharmacotherapies which may be associated with glucocorticoid use and the common drug interactions which are concerned, because that may advocate the alteration of the doses. So the first one is the anticonvulsants, example carbamazepine or phenobarbital or phenytoin. These may have kinetic interactions and may reduce the glucocorticoid exposure and efficiency, rather efficacy, and which may persist even after discontinuation of anticonvulsant. And please note that patients using anticonvulsant usually have to use it for a long time, and even patients with adrenal insufficiency also may have to use it for a long time. So for this, it is very necessary to alter the dose of the glucocorticoid. The dose escalation might be required because of the lower exposure because of concomitant anticonvulsants. With anticoagulants, it may actually have the increased effect of anticoagulants, so INR may increase, and there is an increased risk of bleeding, and that may actually may necessitate the alteration of the dose of anticoagulants. Regarding antifungals, now azoles themselves, they can cause adrenal insufficiency, and azoles has to be avoided in these patients, has to be withdrawn in patients with adrenal insufficiency. But otherwise, azoles can increase glucocorticoid exposure and toxicity. So we have to monitor concurrent use of signs of glucocorticoid overdose in these patients, and we have to try to avoid these azoles because they are also one of the etiological causes. Anti-diabetic agents, I have a separate slide on the management of concomitant diabetes in patients undergoing steroid therapy or patients developing altered glycemic status due to steroid therapy. Regarding antibiotics, particularly the macrolides, example clarithromycin, again that can lead to increased glucocorticoid exposure and toxicity. So please monitor the concurrent use and signs of glucocorticoid overdose in terms of the hypertension, hyperglycemia, or also fluid retention, and may require dose alteration if you are using prednisolone, for example. Regarding antiretrovirals, so there was a question with the antiretrovirals earlier. So they're from the drug interaction perspective, patients having antiretroviral drugs, particularly atazanavir, indinavir, or ritonavir, these patients has been shown that they actually, again through kinetic interactions, increase glucocorticoid exposure and toxicity. And on the other hand, there is a vice versa interaction. Dexamethasone may increase the levels of indinavir and saquinavir. So you have to again alter, may need to be very vigilant regarding the adverse events from glucocorticoids, and also please monitor the antiviral efficacy of indinavir and saquinavir if the patient is taking dexamethasone. Regarding other anti-infectives, again, other like efavirenz, nevirapine, and also rifampin in patients having TIP, these can reduce glucocorticoid efficacy, and this can actually persist even after stopping of these drugs. And as we all know that patients having antiretroviral treatment or TB may need a prolonged treatment, and in these patients, these glucocorticoid exposure may reduce, so we have to increase the dose. Diuretics, now again, as we have discussed, that diuretics should be avoided in patients with these adrenal insufficiency, in particular spironolactone, but also because glucocorticoids can increase the calorific effects of these diuretics. Otherwise, we should avoid these drugs like the azoles. Regarding live vaccines, because we may also have to deal with some patients may be requiring some live vaccines. These patients may be more risky because there is immunosuppression. Lastly, with NSAID use, there is a chance of increased risk of GI ulcers, and consider the use of PPIs if the patient is at the risk of GI ulcers and GI bleeding as well. So these are the common classes of the interacting drugs which may have adverse impact with glucocorticoid use. In general, whenever to actually ameliorate glucocortical induced adverse effects, so treat the we have to prescribe the steroid glucocorticoid at the lowest effective dose for the lowest possible time, but many of our patients may need a prolonged lifetime treatment, and advise the patients to carry a steroid treatment card. But as Professor Arindam has also mentioned, that this is a more westernized concept, and we have to have our own alternative for this, and seek medical attention if there is experience mood or behavioral changes, avoid infections, avoid persons having infections, not to discontinue glucocorticoid therapy abruptly until advised by the physicians, particularly in cases of patients having infections, and also adopt the usual lifestyle measures to counteract the metabolic syndrome and related stuffs, and regularly monitor signs and symptoms of adverse events of glucocorticoids. So I will also I have put a couple of slides on particularly the treatment of diabetes in patients having steroid-induced glucocortical-induced diabetes. So in these patients, we have to measure the blood glucose, the capillary blood glucose. This is actually this actually shows the algorithm of the management. The CBG reading has to be done, and the target is 6 to 10 millimole per liter. We all know that 1 millimole per liter is 18 milligram per DL. The acceptable range can be between 4 to 12. So we can add gliclazide 40 milligram with breakfast and increase the dose if the targets are not reached. So please note that these are all for glucocortical-induced diabetes, not in patients who already had existing diabetes. For those patients, I have another slide. If there is no symptom of hypoglycemia experienced by the patients, despite on 160 milligram, consider the titration of dose to 240 milligram also. So if still there is no improvement on maximum dose, consider adding or evening dose of gliclazide. Even for insulin, we need NPH and commence 10 units per daily in the morning and titrate every 24 hours. So discharge and patient also still needs monitoring. In these patients, if steroid treatment is ceased in hospital and hypoglycemia has resolved, so blood glucose monitoring can be discontinued post-discharge. And if steroids are discontinued prior to discharge and hypoglycemia persists, then continue monitoring until normal hypoglycemia returns. In the next slide, patients already had diabetes in the beginning. So patients who are on oral hypoglycemic agents, we are classified into first patients on oral hypoglycemic agents and patients who are on insulin. If patients are on oral hypoglycemic agents, if there is no hypoglycemic symptoms, we can start with a sulfonylureas like a gliclazide, and actually escalate the dose or add insulin as necessary. And if patients are already requiring insulin, because in both type 1 and type 2 diabetes, we can try the different regimens as once daily, nighttime insulin, transfer this injection to the morning and titrate by 10 to 20%. If patients are requiring twice daily insulin, monitoring the dose will need, and it may need to escalate by 10 to 20% and aim for a CBG and CBG monitoring. And patients who require basal bolus insulin, consider transferring the evening basal dose to the morning and increase the fast acting short insulin by 10 to 20%. So the aim is to 6 to 10 millimole again, and the acceptable range is 4 to 12 millimole. So regarding the management of hyperlipidemia and dyslipidemia in these patients, according to the Framingham risk score, if the risk level is high, that means the Framingham risk score is more than 20%, consider treatment in all patients. If the risk is intermediate between 10 to 19%, and please initiate the primary therapy and try to reduce the LDL cholesterol by more than 50%. The alternate target is to reduce the non-HDL cholesterol by less than 2.6 millimole per liter. And in patients with low Framingham risk score, or in these patients, again, we may have to target the LDL reduction by more than 50%. The last important part is the management of glucocorticoid-induced osteoporosis in adults. So again, osteoporosis in these patients who have a risk that can be stratified based on 10-year fracture risk of less than 10% as low risk, medium risk between 10 to 20%, and more than 20% as high risk. So in patient with low risk, the glucocorticoid dose can be reduced to 7.5 milligram of prednisone or equivalent. And if they require the higher dose, we can give the bisphosphonate like alendronate. And in medium risk patients, if it is glucocorticoid therapy is less than 7.5 milligram per day of prednisolone, we still have to go for an bisphosphonate. And for a high risk patient, at any dose or duration of glucocorticoid actually necessitates the concomitant therapy with a bisphosphonate. And if there is a premenopausal woman and men with less than 50 years of age with having a risk of fragility, glucocorticoid treatment of prednisolone more than 5 actually per day milligram per day actually requires bisphosphonate. And if it is more than 7.5, zoledronic acid is required. And these are the usual management guidelines. And glucocorticoid therapy of more than 3 months also requires this bisphosphonate administration, but there is paucity of data on this particular group. We also need to understand that patients having treatment with a steroid for a long time, because of the feedback inhibition, they can go to an adrenal insufficiency, and no dosage form, dosing, treatment duration, or underlying disease for which adrenal insufficiency can be excluded with certainty. And studies have shown that irrespective of the route of administration of steroids, so it is not only necessary, not only applicable for today's discussion, but in general for a broader perspective, different routes of administration of steroid and different durations of steroid all has a risk of this adrenal insufficiency for because of the suppression of the HPA axis that has been associated, and we have to be vigilant for this. My last slide for this presentation, because we are also dealing with a mineralocorticoid replacement in patients, and while speaking about the clinical pharmacological aspect, the impact of mineralocorticoid replacement in addiction disease has been investigated only in a small number of studies, and data are sparse. And the current mineralocorticoid replacements in addiction disease may not be adequate in some patients, that some studies have shown. And there is evidence that many patients with addiction disease are under replaced and sometimes compensated by over replacement of glucocorticoid, and hence more careful optimization of mineralocorticoid replacement therapy may be of importance in patients with addiction disease to restore quality of life and improve their long-term outcome. So to summarize, we have discussed about the different heterogeneity in the use of steroids in addictions disease, that different patients are using different, has been prescribed different types of steroid, obviously because of lack of uniformity as well as inter-individual variations. We discussed about the different classifications of steroids, the common management of the adverse events in terms of diabetes, and also in patients who had pre-existing diabetes, osteoporosis, and dyslipidemia. And we also discussed the common drug interactions which these patients often encounter, particularly anti-convulsants or HIV drugs, which the patients need to use for a long time, and adverse drug reactions from steroids and the ways of mitigation. So thank you so much for your patient listening.
Thank you very much, Dr. Shoibal Das, because it was an awesome lecture and you had completed it in just 15 minutes. So thank you very much. We are running short of time, so we have to move to our next session, that is our very important panel discussion. And I request you, the speaker, Dr. Shoibal Das and Dr. Arindam Ray, to stay with us for our panel discussion also. So actually we have Professor of Professors today with us during this panel discussion. We have Professor Abhijit Hajra sir and Professor Nilanjan Sengupta sir, and also we have Professor Madhu Chanda Kaur. We have Professor Jyotirmoy Pal. There is some disturbance in his network, so we cannot have him at present, but we have this plethora of Professor of Professors. So we are really thankful to Professor Nilanjan Sengupta sir, Professor Madhu Chanda Kaur madam, and Professor Abhijit Hajra sir for giving us time for this panel discussion. So we have a plan to present few slides for this panel discussion. Okay, so we have a panel discussion on this adrenal insufficiency. We have panelists like Professor Nilanjan Sengupta, Professor Madhu Chanda Kaur, Professor Jyotirmoy Pal, and Professor Abhijit Hajra sir. So first, we want to go to our first panelist, Professor Nilanjan Sengupta sir, with this case. That is a 34-year female admitted with severe vomiting 12 times per day for last 3 days, and 2 episodes which was associated with fresh blood. She had drowsiness and pain abdomen also. So on examination at emergency, the pulse was 110. There is hypotension, there is dehydration. Other systemic examination was normal. The urinary pregnancy test was negative. So she had hypothyroidism on levothyroxine 75 mcg now, but for last 8 months, the dose increment done every 3 months. The records are suggesting like that. And there is a past medical history. For last month, she has visiting gastroenterologist for persisting vomiting. So there is persistent hypotension, which was documented along with hyponatremia for last 4 months. And 4 months back, there was a similar type of symptoms which led to hospital admission. There is a weight loss of 8 kg in last 5 months, from 50 kg to 42 kg. And endoscopy was done 3 months back. There, the report was suggesting gastritis with Mallory Weiss tear. So this is the picture. And the lab results suggesting there is an hyponatremia. Potassium level is 4.8, CRP is 20. There is some leukocytosis along with some eosinophilia, and liver function test, renal parameters are normal. The TSH was done, which was 44.5, despite she is taking medicines regularly, levothyroxine replacement regularly. And the random cortisol was done, and it was 0.36 microgram per DL. That they had start the treatment of adrenal crisis. So now my question to sir is, the delay in diagnosis, which is very obvious due to some various reasons. So how we can prevent it?
Thank you, Shambho. Am I audible?
Yes, sir.
Yeah. So for organizing this excellent session on Addison's disease, and at the end to wrap up with an instructive case. So if you just look at the case, this patient first, she had primary hypothyroidism. So whenever there is primary hypothyroidism with a lowish blood pressure, patient complaining of weight loss, in primary hypothyroidism, generally the patient tends to put on a few kilos. Mind it, obesity is not a common feature of primary hypothyroidism, contrary to usual belief. However, in primary hypothyroidism, the patient tends to gain 2 to 3 kilos. In the phase of primary hypothyroidism, when the patient is losing weight, having hypotension and vague ill health, I think the only thing is to have a high index of suspicion and do a morning basal cortisol. And if the cortisol had come out to be less than 1, I think even without the stress, without the crisis at that point of time, it would have come less than 6.5, and that would have alerted biochemically to the adrenal insufficiency. That apart, the patient had pigmentation of the skin creases and mucosal pigmentation, which probably the clinicians missed it. Now, actually, with the COVID pandemic going on, to be very honest, many of us, the clinicians, are also a little bit wary of, now we are seeing through our masks and face shields, okay, we have to take our protection, fine, but the basic clinical examinations, at least she had certain telltale features of primary adrenal insufficiency in weight loss. Primary hypothyroidism itself should raise a suspicion of concomitant adrenal insufficiency and the pigmentation. So, and the blood pressure, I think that should have alerted the treating physician to go for a serum cortisol and maybe a paired ACTH that was available, and that would have made the diagnosis pretty earlier without the necessity for hospital admission and emergency management of an Addisonian crisis.
If I may put in a word, one of the reasons for a low index of suspicion could be that primary adrenal insufficiency or Addison's disease is a relatively uncommon diagnosis in medicine practice. So what would you say is the prevalence in this part of the country or in India in general?
Even in endocrine practice, it is quite rare. That is primary adrenal insufficiency. Much more common is probably a secondary adrenal insufficiency, which is iatrogenic, which has been discussed. Arindam, could you come up with any data which is what is the prevalence of Addison's in this part of the country. We know in this part of the world, tuberculosis is the most common cause of Addison's disease, whereas globally it is autoimmune adrenalitis. Still in India, probably tuberculosis is common, though autoimmune adrenalitis is picking up quite rapidly, giving tuberculosis around for its money. The other fungal granulomas are also the causes, but I think it is rather rare, even in endocrine practice, so one has to have a high index of suspicion. Thumb rule that what I say, if you get all patients of primary hypothyroidism, if you advise a serum cortisol, many a time that may appear a wastage of resources, but sometimes you will be rewarded with picking up hypocortisolism because the features are quite non-specific and overlapping. Vague ill health, maybe an abdominal pain, weakness, weight loss. So these are quite non-specific.
Can I just add one word that when a patient of hypothyroidism, all the features you told that the symptoms of additions like the hypotension, the weight loss. So these all goes in against of hypothyroid. So in hypothyroid, there is a bit 1 or 2 kg of weight gain. There is a diastolic hypertension. So when a patient with hypothyroidism comes with a postural drop or postural hypotension or weight loss, anorexia, with this kind of hyperpigmentation, definitely we have to think of some additions disease associated. It was very important.
Maybe the hyperpigmentation was missed.
Because of the Indian color, texture,
missed,
we often
but
missed.
No, if you do not specifically look at hyperpigmentation, if you don't have an index of suspicion, you won't look at the palm or the mucosa because the patient will not volunteer that she is getting dark because we are, as it is, dark skinned. So that you will have to give leading questions to uncover those features. However, blood pressure should have not been missed, and weight loss.
Yes, sir. Sir, another issue that happened here in this particular case that we had seen, that management of hypothyroidism. So as the TSH was not controlled, there was an increasing the dose of L-thyroxine replacement, and it was continuing for last 8 months. But the TSH, we had not reached the goal of the TSH target. So what is your comment on that? How much rational without treating or without diagnosing the Addison's disease, if we just increase the dose of L-thyroxine, so is it?
First, that can be a recipe for disaster because that can increase the metabolism. Even if you can restore euthyroidism, that can restore the metabolism and will make a subtle adrenal insufficiency more apparent, more overt, and can push the patient towards an Addisonian crisis. But that apart, if the TSH was not normalizing with levothyroxine, having ensured that the compliance is reasonable, you have to think whether there is any other malabsorption associated with it because in a polyglandular setting, a celiac disease may be co-associated. So that has to also to be kept in mind.
Yes, sir. So
another point I want to add that this patient have a severe vomiting for last few months. Okay, so usually we have to give some prokinetics or pantoprazole or any PPIs like that. So usually there should be a gap of at least 4 hours with the levothyroxine and this PPI. Otherwise, they will hamper the levothyroxine absorption. So it's very important. We used to keep the PPI prokinetic combination in the morning hours before breakfast. So and patient used to take it with levothyroxine. So there is we also see that the levothyroxine absorption is hampered and patient have a gradual rise the requirement of this levothyroxine.
Absolutely. This is a very, very practical thing. Means Obijit also, let me say, in my practice, I'm not looking into it, but if you could look into it methodically, the main confounder which we are getting these days, which is impairing normalization of T4, T3 and TSH with exogenously administered levothyroxine is the interaction with PPIs mainly and H2RAs, mainly pantoprazole, omeprazole, because these are used more often these days than the H2 receptor antagonists. Rather than iron, rather than calcium, it is the PPIs, because PPIs are often taken without prescription of physician and gastroenterologist. The patients learn to take PPIs just like that, and both of them are given in the morning. That's the main problem. Calcium, maybe they are taking after lunch or dinner, or iron, that doesn't cause much of practical interference, but PPIs, yes, very much.
Yes, sir. So this is very common in our setting, as you had also mentioned. And as you were talking about that polyendocrine syndrome, so actually, what are the key points should we remember as a primary caregiver or physician to deal with autoimmune polyendocrine syndrome?
Just as I said, if you come across a gross primary hypothyroidism, you should exclude adrenal insufficiency. Similarly, if you come across primary adrenal insufficiency, you should exclude other common and rare polyendocrinopathy syndromes. The constellations have been grouped into two main diseases, which have been classically called PGA type 1 and type 2. The type 1 consists of candidiasis, hypoparathyroidism, ectodermal dysplasia, and Addison's disease. And type 2, the main features are type 1 diabetes, Addison's, and autoimmune thyroid disorders. Then there is also another syndrome, the Algrove syndrome, which again, it's very good for case reports and all these things. It's very rare, but Algrove syndrome also has to be kept in mind. That is achalasia, Addison's, and allocrinia. I think Algrove will not be missed because the features are still, it's very rare, but should it occur, it will not be missed because the features are quite stark. But it is just a subtle Addison that may be missed. And in a Dutch registry, it was shown, this is not in India, it's in Netherlands, that it took an average of 8 years for adrenal insufficiency to be diagnosed from the probable onset of the disease. In one Dutch registry study, that was the finding.
So patients with these findings routinely be screened for diabetes?
Yeah, of course. They should be screened for diabetes and at least the thyroid autoimmunity, which is also quite common.
Okay, sir. And also in this case, we understand the importance of random cortisol level. So what is your comment on that also regarding that random cortisol level in emergency setting? And when to, if like this case, when to again recheck the cortisol level and ACTH level, or even the tetrachocycline challenge test, when to do that? Because already in emergency, the patients had been started with steroids. So your comment on that, sir?
Yeah, that's a very, very pertinent practical question. Random cortisol level in a chronic setting has practically no value. But in an acute setting, it may be life-saving because when the patient lands up in emergency reception, it is 3 p.m. in the evening and you want to say that I want to do a morning cortisol for my interpretation purposes. I will keep the patient waiting till next morning and not giving any glucocorticoids. The patient may simply die in between. So if facilities are there, you draw the blood, refrigerate it, and send for cortisol assay. Here, like in a clinical setting with a random cortisol less than 5 or less than 6.5 microgram per deciliter is quite suggestive of adrenal insufficiency. However, situations may arise that you do not get the time to draw blood and preserve it and send it for cortisol assay. Suppose if it occurs in a peripheral health institution, there presume that the patient is having adrenal insufficiency, resuscitate the patient with fluids, electrolytes, and glucocorticoids first. Let the patient be saved first, then the patient be stabilized. Then you refer the patient to a higher center, to an endocrinologist who can actually, we have a protocol of tapering of the steroid to the physiologic dose, then maybe shift to hydrocortisone, say 10 milligram per day, or when the hydrocortisone requirement is 5 milligram per day, then we stop it or shift to a prednisolone for a couple of days because hydrocortisone will have assay interference with the cortisol assays. then we shift to prednisolone for a couple of days, or stop it altogether if you're courageous enough to stop, and then do the cortisol and, if possible, the ACTH assay. So I think in an acute setting, saving the life of the patient by liberal glucocorticoid replacement intravenously, followed by oral glucocorticoid replacement, initially on a supraphysiologic dose, tapering down to the physiologic dose, is most important. Then, of course, the axis can be tested as and when the physician deems fit.
Thank you, sir. Thank you very much. So we are now moving to our next panelist. We have Professor Madhu Chanda Kaur, madam, who is the clinical director of the Department of Oncology at Peerless Hospital. So, madam, welcome to this panel discussion. So we have a hypothetical case like this: a 68-year male admitted with several weakness for last few weeks, and adenomia, progressive loss of deambulation, and having become the bedridden for last 20 days before the hospitalization. Now, almost 9 months, he was diagnosed with small cell lung cancer. He's known hypertensive on amlodipine 5 mg, but for last 1 month, amlodipine was deprescribed due to this low blood pressure. On admission, there was dehydration. The BP was 77/45. Hemoglobin was 11.2. Sodium is 116. Potassium 6.1. Creatinine is 3.09, and BUN is 143. So there is some pre-renal azotemia with CRP of 5.86. So he was initiated with normal saline infusion, cation exchange regime. Then after 24 hours, remained hypotensive. There is some improvement in the lab results, like sodium 126, potassium 5.4, creatinine becomes 1.78 and 149. And then by seeing this type of thing, the adrenal function assessment was done, and we can found there is some adrenal insufficiency, primary adrenal insufficiency. In the CT abdomen also, it was found there is a large nodular enlargement of both adrenal glands. So now the question is, madam, there is interaction between the tumor, immune, and endocrine system in such cases. So what is your comment on how to deal with this overlapping symptomatology? Because in terminal stage cancer or chemotherapy-induced adverse effects, the similar symptoms appear. So how we can distinguish it from adrenal insufficiency? So what is your comment, madam?
It's very nice that you brought up this issue amongst oncologists, because we are the last people who actually think of adrenal insufficiency, and instead we always think that it is due to the chemotherapy or it is due to terminal cancer. So AI screening is not done by the oncologist, and awareness level has to be increased. So that is my first message, that we underdiagnose AI in oncology patients. Number one. Number two, as you pointed out, many causes for all this type of parameters that you showed. Metastasis which you have described in this patient. Those patients who have metastasis, they must be quite advanced, because as we know, around 90% of the adrenal tissue has to be deranged before we can get this type of AI. So that is the cancer patients have got a lot of drugs that are now used which cause AI. Number four is, I'll enumerate the drugs later. Number four is, we all know that cancer has got physical and mental stress. So the axis, hypothalamic pituitary adrenal axis, is always very activated. So in this background, let me come to the moot point. When do we suspect that this patient has got AI? Usually, even after the sides, the dyselectrolytemia continues, the hypotension continues, we should do a AI screening. but I very much accept that we do not do it regularly. And this type of program is making me more aware that we should do it more frequently. But any cancer patient can have an opportunistic infection like tuberculosis, histoplasmosis that we get. So we must be aware of that also. And previously we had some HIV-related adrenal insufficiency also. So these were the experience previous years. Currently we don't have. There are drugs that we use that can cause adrenal insufficiency. And many of you know that tyrosine kinase inhibitors have become very important in the treatment, in the targeted treatment of cancer. And tyrosine kinase inhibitors can cause hypothyroidism. They can also cause adrenal insufficiency. Similarly, a lot of drugs that are used in prostate cancer now, the hormone manipulation therapy, there we routinely give prednisone 5 mg BD in the drugs that we use to prevent adrenal insufficiency. There is immunotherapy nowadays, which is available, and immunotherapy-related adrenal insufficiency is also known. Platinum-related adrenal insufficiency is also known. But unfortunately, AI screening is. So I would request Shambho to spread this message even amongst the oncophysicians that they should do the AI screening in those cases which do not really respond to the antiemetics and where the disease is not so much advanced to cause such fatigue. The fourth point which I would like to say is adrenal insufficiency can be the presenting feature also in an occult malignancy, or it can be the first indication of a recurrence in a malignancy. So it has got important clinical suspect.
Thank you, madam. Thank you very much. And as you had also already mentioned that sometimes or most of the time, what happened, the adrenal metastasis may present as a Cushing syndrome-like features. There will be some excess hormone that may come into our blood. And after a few times when it becomes advanced, the adrenal gland become destroyed, then the features of this type of adrenal insufficiency.
Very important. Very important.
Yes, madam. So this is a very important subject for oncologists too, and like this type of things. And
correct.
what
has been a very good paper from Korea. Prednisone Dexamethasone, antiemetic, and as usually it is used every 3 weeks, 20 milligram dexamethasone. But even with that, 15% of patients ended with adrenal insufficiency. So this really is a clarion call, and we should not underdiagnose AI in oncology patients.
Yes.
In childhood leukemia, the effect is seen maximum because they have prolonged steroids, especially the acute lymphoblastic leukemia. And here, to return to the previous status takes nearly 6 to 12 months after discontinuation of the steroids. So these are the two areas which I thought we must share in this podium, in this forum.
Thank you, madam. Thank you. And
madam, if I
yes,
ask
sir.
madam a question, madam, you mentioned that the small molecule tyrosine kinase inhibitors, like say gefitinib, which is used in lung cancer, they can
Yes.
cause AI. How common is this as an adverse effect among this group of molecules?
Professor Hajra, I think it is very important we should have our own experience. As far as I'm concerned, I have 2-3 anecdotal cases where I picked it up, but hypothyroidism was much more common. Say in the literature, it will be around 2 to 3%.
Okay.
Okay, madam. And also you had mentioned rightly while you were talking about that childhood leukemia management. So many of our cancer patients, they have asymptomatic adrenal dysfunction, and they may have requires steroids for something else, but sudden withdrawal of those steroids that may lead to this type of adrenal crisis, and we need to suspect that. and you had beautifully described that. So thank you.
Shambho,
Yes,
last
madam.
point I would like to say is that somebody talked very beautifully about the co-prescriptions which can cause drug-drug interactions. And I think oncology patients are having maximum number of co-prescriptions. Suppose there's a brain metastasis, they will have this anti-epileptics along with the usual drugs that they have. And there are so many others, like you mentioned, some antibiotics, antivirals. So we should all be very careful that co-prescriptions where they are having AI screening as well. So this is my message today.
Yes, madam. Thank you, madam. So we are now moving to our next. So this is one logical study that I had shown here, that how it is common among the cancer patients. So this is a study from Australia. So we had discussed this already. So we are now moving to Professor Abhijit Hajra, sir. So, sir, we have this type of hypothetical case, like a 41-year-old male diabetic, hypertensive, post-COVID mucormycosis patient, now admitted with severe vomiting and poor oral intake. He's feeling weak, and this weakness acutely worsened in the last 2 to 3 weeks before admission. So what are the medicines he is taking? That is insulin, atorvastatin. He's also on topiramate for migraine-like illness. He is taking losartan, pantoprazole. Now for this mucormycosis, he is taking posaconazole 300 milligram daily. Blood pressure is 110/60. The pulse is 110. Tachycardia is here. There is some hypokalemia, also hyponatremia. The serum cortisol we can see in the lower side 1.38, and 1 hour post-entropin IM results, that is not that much rise in the serum cortisol level. It is only 3.38, and the serum ACTH is higher side 147.9, and the CECT whole abdomen was done, which had shown the bilateral thickened adrenal glands that consistent with hyperplasia. So my question to you, sir, so how we can suspect drug-induced hypoadrenalism? And while in this particular case, when there is a detailed medication history for last 5 months, the patient also taking some unauthorized over-the-counter traditional medicines periodically for his joint pain. So what is your comment, sir?
Shambho, you have asked me a question which will require real pharmacological detective work. Okay, so we know that primary adrenal insufficiency, Addison's disease, is relatively uncommon, but secondary causes of hypoadrenalism are more common, and drugs contribute quite a large share to the secondary causes. Now, in the context of this particular case, the index of suspicion won't be very high for drugs because they have given a post-COVID mucormycosis patient. The plethora of symptoms we have seen in the context of COVID or in the post-COVID scenario can match any of these symptoms. And mucormycosis patients is right now receiving posaconazole. He may have received liposomal amphotericin B earlier. So those drugs may also have caused dyselectrolytemia. So there are some drugs which are definitely known causes of drug-induced hypoadrenalism. You take mitotane, you take aminoglutamide, suramine, drugs like that. But there are also other drugs which are not that commonly implicated, but still may be responsible for secondary hypoadrenalism. So I think in the context of this particular patients who are having a lot of morbidities and at the same time would be on multiple drugs, we should keep the possibility of drug-induced hypoadrenalism in mind, particularly considering that the BP is on the lower side. There is hyponatremia, which seems to be a little bit persistent, and the other biochemical abnormalities in cortisol and ACTH. So a physician should again have that index of suspicion that AI could be one of the reasons that explains at least part of the symptomatology. What was your next question?
Yes, sir. So the next question is also that as the patient was also taking some OTC, maybe this could be possible because already OTC we know sometimes which is unauthorized traditional medicine.
The traditional medicines we cannot comment on that way. We know that some Ayurvedic medicines, they have glucocorticoid-like activity, glycyrrhiza glabra, for instance. But the more common problem is that we have seen cases where OTC medicines actually have been mixed with corticosteroids. So rather than causing hypoadrenalism, they would be causing Cushing syndrome. So it's really difficult to comment on this, whether there would be any OTC traditional medicines which would have suppressive effects on adrenal function. Regarding the prognosis of drug-induced hypoadrenalism, if we're able to identify the offending drug and replace it with suitable alternatives or withdraw it, I think the prognosis should be good, but I really request the opinion of endocrinologists on this issue.
Yeah. So may I request Dr. Arindam Ray to comment on this? Dr. Arindam Ray?
Arindam is there or he has logged out? So,
Oh, sir.
May I comment? Yeah.
Yes, sir. Yes, sir. Please.
I think, well, those over-the-counter medicines, if Ayurvedic or other systems, if they make some glucocorticoids, they may have Cushingite features if the glucocorticoid given is in excess. But if it is not given in excess, the person is exposed to some surreptitious glucocorticoid therapy that may be sufficient enough to suppress the hypothalamo-pituitary adrenal axis. And now, if the patient stops that medicine, can go into an adrenal crisis. So even without causing Cushing's, an adrenal crisis can occur that way, though rare, that can happen. And regarding how long the axis will remain suppressed, again, depends upon the dose of exposure and duration of exposure. But with glucocorticoids, whether given with the knowledge of the patient or without the knowledge of the patient and the physician, but at times it may take even years for the axis to recover. 6 months to 1 year after stopping, it may recur. So it's actually dependent upon the dose of the glucocorticoid exposure, the duration, and pleomorphism in 11-beta HSD 1 and 2, because some persons are more susceptible to glucocorticoids while others are protected because of polymorphism in 11-beta HSD 1 and HSD 2, which actually affects conversion between cortisol and cortisone.
Just out of curiosity, if you take this potent synthetic steroids like dexamethasone or betamethasone compared to, let's say, hydrocortisone or prednisolone, would your recovery be delayed further?
Yeah, the recovery would be delayed because these are not only potent, they are longer acting. With hydrocortisone, at least the axis may get some time to be off steroid suppression. But if there is a long continued suppression with a longer acting agent, the axis suppression is even more, which is why now in children with where we have to use glucocorticoids, hydrocortisone is preferred over the longer acting steroids because of the risk of axis suppression and the risk of growth retardation that is much more with the longer acting potent steroids.
Now, nowadays in India, we have another synthetic steroid being marketed, Deflazacort. And the people marketing them are claiming that it's less prone to cause HP axis suppression. Now, is that true?
Yeah, I have gone through those comments, but I'm not convinced because basically the axis suppression is dependent upon the degree, basically speaking, the degree and the duration of steroid that is equivalent to hydrocortisone. So means one issue of discussion is whether it's a potent steroid, whether it's a long-acting one. That is one issue. And another issue is that what is the hydrocortisone equivalent? Any hydrocortisone equivalent of more than 15 milligram per day for more than 15 days is likely to cause some degree of suppression of the hypothalamus-pituitary adrenal axis. So if deflazacort is that equivalent, even deflazacort is given for more than 2 weeks, there would be some degree of suppression. Of course, if it is of a shorter duration, on stoppage, the recovery would be easier. If it is a longer duration, the recovery may take some more time. But some degree of suppression occurs, and depending upon the individual susceptibility of the axis to suppression by steroids is also important.
Thank you, sir. Thank you. So we have to come to our last question to Professor Abhijit Hajra, sir. So how the pharmacology or therapeutics OPD you think that could be beneficial for the patients to prevent iatrogenic harm, including this type of drug-induced hypoadrenalism?
Look, Dr. Shambhu, I have a little problem with these semantics. What do you mean by pharmacology or therapeutics OPD? An OPD is an OPD. You may have pharmacologists manning them. So personally, I believe that if you are a good clinical pharmacologist, you'll bring the pharmacologist perspective into the viewpoint when you are analyzing the cases in conjunction with your hardcore clinical colleagues. And therefore, if you are there as part of the team, then definitely you'll be able to spur your thoughts or spur your actions towards that end, thinking in terms of drug-induced harm and iatrogenic injury, which sometimes clinicians tend to overlook. They look for other kinds of diagnosis, sometimes rarer diagnosis, which perspective can be set right by a clinical pharmacologist in the team. So definitely, if you can bring in a clinical pharmacologist viewpoint, these drug-induced problems may get identified faster, and therefore you may take appropriate remedial action.
Thank you, sir. Thank you very much. So we have to end here. I am again really thankful to all the panelists who had given their valuable time with us. Also, we are really thankful to Dr. Arindam Ray and Dr. Shoibal Das who had stayed with us during this panel discussion. So any final take for our delegates who had present? Professor Nilanjan Sengupta, sir.
I only would love to thank you for organizing this sort of interactive, interdisciplinary webinar on Addison's disease, which are not held this much, that much because these are not, they do not have corporate sponsor backing. So it is really a learning experience, and adrenal insufficiency is one thing which detected can be treated very easily, and which missed or undetected can kill the patient. So as Dr. Madhuchanda Kaur was pointing out, sensitizing every clinician for picking up adrenal insufficiency and not treating. If they can pick up, and if they can't treat, at least refer to the respective specialist is very important. This sort of programs, sensitizing people on conditions like adrenal insufficiency, which may be life-threatening if missed, is very much welcome. Please keep it up and continue the good work that you are doing on the academic front.
Thank you very much, sir. So now may I request Professor Abhijit Hajra, sir, to have his concluding remarks.
As Dr. Sengupta has said, that this sort of interactive, interdisciplinary discussion, particularly on a topic which is not so commonly discussed, is enlightening. It helps us to not only refresh our knowledge, but in the light of some of the cases that we have discussed today, it also helps to refocus our own things beyond our own immediate sphere. So I think you have done a great job on behalf of IPS West Bengal, and please keep it up. Thank you. And I would sincerely like to thank all the participants who are here with us till it's past 10 o'clock now. So thank you, everybody.
Thank you, sir. Thank you,
Right.
all the respected panelists. So good night, and we will see you in our next academic feast. Thank you.